Good morning, everyone. Good morning, everyone. Can you hear me? All the way in the back, can you hear me? It's good? Good sound? Great. So, very warm welcome, everyone. And thank you so much for coming here in this beautiful sunny day outside. Thank you for sharing this morning with us. We have a long and extensive program ahead of us, so we start on time, and it's now 9 o'clock. My name is Anne Hoskell Haugen. I'm a freelance journalist, and I will be the moderator for today. This day we will divide in two. We will be here from, the program is from 9 to 12:15. The first part of the program, we will have three mini lectures from very prominent people with a lot of knowledge. As you might have noticed, I'm speaking English. And the reason for that is that we have an international guest with us, Sandra Giuliano. And as a courtesy to her, we speak English in this first part of the program so she can actually understand what's going on. Then for the second part of the program, after a 15-minute break, where you will get some coffee and some baked goods, I think it's already in the back, we will have a panel discussion here on stage. And after that, we will have a mingling, and we encourage you all to stay. It's free lunch. It's free lunch, yeah. So stay. And it's a great opportunity for you all to talk together with each other and also with the people you will meet here on stage today. So, a few practical information. There are toilets all the way downstairs in the basement, and in case of fire, you need to leave the building through the main door and do not use the elevator. You all know it, but we have to say it. And the second piece of practical information I will give is that we really encourage you to ask questions. You will get the opportunity to ask questions both after the mini lectures that we will have on stage and also after the panel discussion. You can do this in two different ways. You can use this service called Slido. I don't know if you know it before, I didn't, but it's really easy. You just log on to slido.com, and you will get the opportunity to enter this code, and you can just write your question. And then we will manage the questions from the stage. You can also vote the questions, like the questions you like the most or find most interesting. So it comes up on top, and we will choose that one. If you don't want to use this service, you can use the old-fashioned way. Raise your hand, get a microphone, and we will do it that way as well. And please wait for the microphone, because we're streaming the whole program, and we have quite a few people following us on the stream. So if you don't use the microphone, although you have a very good voice, they will not hear you. Okay, so I think that's everything I have to say before you will get the... Oh, I have to stand here because of the streaming. They told me to stand here. The real welcome you will get from the CEO of the Norwegian Dairy Council. Ida Berg Hauge has been with the Dairy Council since its very beginning. So you can celebrate 20 years loving milk and dairy products. You can follow her on Twitter, Melk.ida, I saw, very interesting. And she will now give you a welcome and talk about the content of the seminar and a bit about how you are working. So welcome up to the stage, Ida Berg Hauge.
Thank you. Okay. Welcome, everybody. My name is Ida, Melk-Ida, as I like to call me, and then you understand where I am standing. I do like milk very much. I think it's very joyful to work with, and I've done for a long time. Welcome to Sandra and to the rest of you. I'm probably going to switch a little bit between English and Norwegian, but I'm sure you're going to follow that. My slides are in Norwegian. I think that's okay. And welcome to everybody also on the stream. I think we have almost 100 people on stream, or maybe at least 90, which I think is very good. But we very much also like you that you are here in the room, because it's good interaction to have people in the room as well. Just a few words about Opplysningskontoret for Meieriprodukter, as we call it in Norwegian. Melk.no is a very long word, Norwegian Dairy Council in English. And our task is actually to make fact-based relevant content and do the talk about this, talk about it based on knowledge about, we give advice and we give inspiration. And for us, it's important to be generic, or merkenøytral as we call it. So when we talk to both to the consumers and we talk to important people, key opinion leaders, as you all are here in the room and on stream. And our focus is very much based on nutrition. We think that is important, and this is kind of the essence of the milk product, is the nutrients of milk. That's why we talk a lot about it. And there are a lot of discussions about, of course, nutrients. Also, we are very eager to talk about the nutritional advice, the guidelines from the health authorities. We think that is very important. So I think we are actually talking even more than the health authorities themselves sometimes about their advice. And we are very also, for us, it's very important to be science-based. So we try to follow the science. There's a lot of science coming out. And we try to, when we talk, we try to say, this is actually what the science says. And if you are curious about things, you probably have a lot of questions about dairy when it comes to everything from production to sustainability to nutrition, whatever. We have something we call Melkefakta on Melk.no. And there we have collected a lot of the questions that we get, and we try to give some good answers on that. But we are also, of course, open to hear and discuss with you and hear from you if you have things that you think we are not covering and that we should cover. For us, when we call the Opplysningskontoret, the communication work, Melk.no is a hub for us. We work, of course, in social media. We travel around and we do some educational stuff. So we go and meet the students that are going to be mat- og helselærere or are going to be nutritional teachers. So we travel around to do some tutoring to them. We work with the press, and of course we have these kind of seminars. Yes. And then we also, I forgot one thing. We have this YouTube channel, and it's called, actually now it's called Melk Ernæring, and that's where we put out our different seminars. So this seminar will also be there, so you will be able to see it afterwards. And they actually have good content. There are a lot of different seminars over the years that you will be able to find there. I'm not going to stand here for a long time because you're not here to listen to me, but I just want to emphasize one thing, and this is for us very important, is the nutritional guideline, the kostråd about dairy. Not that many knows about the kostråd of dairy, actually. We talk a lot about meat, we talk a lot about fish, we talk a lot about grain, we talk a lot about fruit and vegetables, of course, we talk about fish. We find, at least, that dairy is not talked that much about. It is in the nutritional guideline for dairy as well. And it says å spise daglig inntak av magre meieriprodukter. To eat daily lean dairy products. But what they actually did is that they also emphasized a few years ago, they emphasized and said that when we talk about daily intake, we mean that 2 out of 3 portions should be milk or yogurt. And that is because of the content of iodine. We won't talk that much about iodine today, but we know it's a big lack of iodine. There's an iron deficiency among pregnant women, among also other women. And the government or the health authorities are quite concerned about that. So that's why they came and said we need to have 2 out of 3 to be milk or dairy. And so that means, because a lot of people eat cheese, but the regular hard yellow cheese, hvitost, gulost, does not contain iodine. So that's why you need to have the milk, or actually brunost, the traditional brunost. We're talking to Sander about the brunost. Also contains a lot of iodine. So we think that's an important, for us, message to talk about. And not that many knows about it. And if you want to get iodine from somewhere else, you have to have a lot of white fish, which we know that people are not eating that much. So it's actually milk and white fish that are the best sources for iodine. So, and also in the new nutritional guidelines that is coming on, you know, probably follow, there's a lot of discussion about the new nutritional guidelines, Nordic nutritional guidelines. They have been very clear on saying that dairy is healthy. So now the Norwegian health authorities are going and looking at revising their nutritional guidelines. So they are coming, the first outline of that is coming before Christmas. So we will know if they will change the guidelines we have today, if they will make some changes, not only for dairy, of course, but for everything. And we really hope that they'll keep the 3-a-day recommendation, because we think it's a very easy recommendation for people to follow. It's very easy to get 3 a day, and it is a good recommendation. And it's hard to get some of the nutrients from other places. Okay, and I'm just going to show you a quick little commercial that we run just to tell you this is about calcium. We kind of find it's important to tell about all the nutrients that are in milk, because a lot of people, especially young people, do not know that. So that's why we made these kind of commercials that you may have seen.
Visste du at ett glass melk gir deg påfyll av ganske mye av det du trenger hver dag? Blant annet kalsium, som er bra for skjelett og tenner. Melk, en naturlig pakke av næringsstoffer. Opplysningskontoret for Meieriprodukter.
So we should translate this is milk, a natural package of nutrients, is that what we call it at the end. So we have a lot of different variations of this. So you're not here to listen to me. You are here to listen to Sandra and all the other good, very good, great speakers that we have. And I think it's very important that we start put more the elderly more on stage and talk about what is happening on the nutritional side of when you get a little bit older. As I become older, of course, I'm getting more interested. I also, yeah, that's how it goes. And also, I have a mother that's 95 years old, so I know something about both the hjemmehjelpstjenesten and the sykehjem. And of course, I have a lot of opinions about that, as everybody else, I'm sure. So I'm very eager to hear what the scientists are going to say, and also have the discussions afterwards. How can we work on this? So over to you, Anne, and thank you for coming here.
So, hand to Ida Berg-Hauge. Thank you so much, Ida. So I'm hoping you're looking forward to this part of the program. I think it will be very interesting. I'm so happy to see the next speaker just running through the door. We were a bit nervous there for a moment, but you're here now. Thank you for that. So the next speaker out you will hear is Haakon Meyer. He is a senior physician and professor at the University of Oslo and the Norwegian Institute of Public Health, Folkehelseinstituttet. I was looking at your resume, and there's no doubt that you have a long experience working with these topics. I even saw your PhD from 1996 concerning exactly what we're talking about today. And the talk you will have today, you have named Prevention of Osteoporosis and Fractures in the Elderly, the Role of Nutrition. So you have 25 minutes. We will help you keeping the time. And please remember the questions. We will have a round of questions afterwards, directly after the speak. And you can, as you remember, you can use the Slido, or you can raise your hand. So please welcome Haakon Meyer up onto the stage. Give him a hand.
Good morning. I thought I had 35 minutes, so I'll have to speak fast. But I had some problems with the tongue yesterday, but hopefully it will work today. It's a blister at the tip of my tongue, which make my English pronunciation a bit hard, but I think we'll manage. Okay, I will talk about nutrition and osteoporosis, and I've been working on this topic for many years. This is a recent review in Lancet Diabetes and Endocrinology. It's not my review, but it's only a few years old. And the authors list up a lot of nutrients and constitutes in the foods which could affect bone. And you can see calcium, magnesium, phosphorus, protein, vitamins, different vitamins, energy, phytoestrogens, omega-3 fatty acids, coffee, tea, dairy products, specific dairy patterns, and trace elements. So there is a lot. However, when it comes to the evidence, it's not, for many of these, it's not very strong, but still it could be important. But first, I would start saying that probably the most important risk factor influenced by nutrition for osteoporotic fracture is a low BMI and weight loss. This is a very important risk factor, and I think it's often underestimated when we talk about nutrition and fracture risk and osteoporosis. And of course, body weight is strongly influenced by energy intake, as you know. So I think it's the main thing. And this is just an example. We made a study in the cohort of Norway. It's a huge study constituting or including 180,000 Norwegian. But in this particular analysis, we focused on the elderly part. And there was, as shown in many other studies, there was a strong association between BMI and hip fracture. And you can see on, do you have a pointer here? Yes, you have a pointer. Let me see. In the middle. There we have BMI here. So very low BMI and high BMI. And you can see that in those with a low BMI, both in women and men, they have increased risk of fracture. There's increased risk on the y-axis. So this is a typical pattern. And this is a meta-analysis where they have collected data from a lot of similar studies. It shows exactly the same pattern. You see an increased risk in those with a low BMI, and particularly so for hip fracture, a very strong gradient. And then you can also see that when you reach around 25, it's not much more to gain. So we are not saying you should have a very high BMI, but you should try to avoid to have a very low BMI. This is a main point. And Ian Reid, he's a professor in endocrinology in New Zealand. He has written a very nice review, and he says the shape of the curves has important clinical implications. It indicates that we should not be encouraging obesity in order to reduce fracture risk, but that nutrition advice should aim to keep BMI values in the upper part of the 20 to 25 BMI range. So I think this is a quite important message. So, as I said, the gradient is even stronger for hip fracture than for other types of osteoporotic fracture. And then if we go to, and then we can ask, why is it so? Why is low BMI associated or a risk factor for increased risk of osteoporosis and fracture? Well, it's so that weight bearing stimulates the skeleton. So NASA, you know, the space agency, US Space Agency, they have a whole program trying to combat osteoporosis in astronauts. Because if you send people out in outer space for a long period, they will lose a lot of bone due to lack of stimulation of the skeleton. And if you sit in a chair, or if you are very slim, the skeleton will be less stimulated. So this is an important part. And then if you don't have much fat and lean muscle mass, then you have less aromatase activity in soft tissue affecting sex hormone concentration. So it comes to especially estrogens. So postmenopausal women have lower levels of estrogens if they are very slim compared to those who are not that slim. And then we have less soft tissue padding over the hip. If I have padding over my hip, I fall. Some of the energy will be absorbed in the padding. And then, importantly, I think, nutrition deficiency. So nutrition provides energy to uphold a decent BMI. But in addition, the second slide I showed you, a lot of trace elements and a lot of vitamins and a lot of this and that. And if you get too little intake of different nutrients, that could affect bone tissue, even if you don't have the strong evidence for all of these elements. But we should definitely try to avoid undernutrition and malnutrition. And just to show you one more slide from this meta-analysis, this is the association after adjustment for BMD. So if you adjust for bone mineral density or osteoporosis, then there is no association between BMI and overall fracture risk except for hip fracture. Still, you have an increased risk in those with low BMI, meaning that probably this soft tissue padding also means a lot. But a lot of the effect on fracture risk is via the bone mineral density and osteoporosis. Okay, now I talked about one of my favorite subjects. So but I think it's very important. And of course, all the foods provided to elderly people is very important also when it comes to energy. And then I will talk about a subject which also is quite popular, and I've been studying it for many years actually, and participated in a number of studies, and it's on vitamin D, and I also include calcium. And this one I should have started to say at the beginning, because the risk of fracture is related to bone strength, bone mineral density, what you can measure in a DEXA machine on a lab, or / osteoporosis, but it's also related to trauma or the risk of falling. And of course, nutrition could also influence on the risk of falling, and I think the next two speakers will talk about that too. So this is also an important element when we talk about prevention of osteoporotic fracture. It's not only preventing osteoporosis, but also reducing the risk of falling. And when it comes to vitamin D and osteoporosis, then the evidence, we would like the evidence to have been much stronger, but actually it's not that strong. And it's a bit surprising. But it turns out to be that summarized evidence from randomized controlled trials only shows a small effect of vitamin D on bone mineral density. So the effect is quite small. But then they have looked closer into it, and two recent trials shows that they found an effect in those with low vitamin D levels. Perhaps you know of this 25-hydroxyvitamin D. They found an effect in those lower than 30 nanomoles per liter. And in Norway, we say this is vitamin D deficiency or vitamin D mangel, whereas between 30 and 50, that's more under desired levels. But it's first when you come under 30, you see this effect. And when it comes to calcium absorption, you have all learned that vitamin D is important for calcium absorption, and it is, but you need to come very low in vitamin D before it affects calcium absorption. So if you're really deficient, then it affects calcium absorption. But if you have a decent concentration of vitamin D in your blood, then it's okay. And then, of course, vitamin D could affect different things, also risk of falling and different aspects of osteoporosis. But this is evidence, and there have been performed many studies, randomized controlled trials. However, the problem is that most of these studies have not included enough people with very low vitamin D status to start with. And as I showed you here, it suggests that if you look at this subgroup, you find something. And this, again, Norwegian data, and we looked at, it's also from a cohort of Norway, but then we measured 25-hydroxyvitamin D in blood samples, and this is risk of hip fracture, and those with low concentration of 25-hydroxy, they had increased risk of hip fracture. And up here it's quite uncertain, but it seems to be, the problem seems to be in those with a low vitamin D concentration, as shown is in this study on bone mineral density. And then we go to the Cochrane review, and vitamin D and vitamin D analogs for preventing fracture in the postmenopausal women. There are a lot of such reviews out, but this is one of them. And here you see studies intervening with vitamin D only, comparing vitamin D to placebo. And here you also find our study from Oslo, this one. And we didn't find anything, and the overall result here is a relative risk of 1.12 in those receiving vitamin D compared to placebo, so no effect of giving vitamin D alone. However, if those smart enough to combine vitamin D and calcium, they found an effect. This is on hip fracture, and here you see the different study, but this is a summary estimate. A relative risk of 0.82 or 18% decreased risk of hip fracture. And it seems to be in the more fragile elderly you find this effect. So, conclusion from randomized trials, and randomized trials do not necessarily give the whole picture, but we have a lot of randomized trials, so we have to focus on them to start with, and it shows that vitamin D supplementation, low dose, combined with calcium, decrease the incidence of fracture moderately in elderly people. So if you combine it. However, there is insufficient evidence that in the dose tested, vitamin D supplements alone prevent fracture. And recently, a number of large randomized trials testing out high-dose vitamin D has shown exactly the same result, no effect of vitamin D alone. Let me see what's the time now. It's 9:25. Yes, fine. So I will talk, but just a few words more. It does not mean we shouldn't provide enough vitamin D and calcium, because I'm more afraid for those getting far too little. So if you have enough, perhaps we should be satisfied. You don't achieve to receive more than enough, but enough is still important, I think. Okay, foods. We could talk a long time on it. I do not have time, but it's a milk seminar in a way, and some of you might recall a publication in British Medical Journal from Sweden claiming that the intake of milk increased the risk of fracture and increased mortality, and it was quite debated, but it received a lot of attention, this article. And then we said, well, let's try it out in Norway. Norway is not that different from Sweden. So we did the same type of analysis in Norway, using 2 very large data sets. And the conclusion here is that we did not find any association between milk intake and fracture risk, which was relieving for us because we didn't find increased risk as the Swedes did. Again, we can't say we didn't have enough people drinking too little milk or receiving too little calcium to really look into the subgroup with very low intake. So still there could be an effect there. But I think it was reassuring that we did not find increased risk as the Swedes did. And then I was part of a risk-benefit analysis on fish intake in the Norwegian fish intake. It was not limited to the Norwegian population, but one topic there was fish intake and the risk of osteoporosis and fracture. And here we list up the included study. It was a systematic review, and it's one study from Germany, China, US, Norway, and US. And the overall conclusion, the evidence that high fish consumption may lower the risk of hip fracture is graded limited suggestive. So it could be something, but we don't really know. It was hinted at a decreased risk of fracture by increasing intake of fish. Yeah. Okay. And then dietary patterns, and there also been a lot of study on dietary patterns, and this is Mediterranean diet, and it's a meta-analysis, and they conclude adherence to a Mediterranean diet was associated with a reduced risk of fracture as well as with a higher mean bone mineral density. So it seems to be beneficial to have a good recommended diet, actually. And then there are a lot of vegetarians and vegans, and they also have made a meta-analysis on this topic. And they say here results, it was a systematic review, 20 studies including 37,000 participants, met the inclusion criteria. And then the vegetarians and vegans had lower BMD, or lower bone mass, at the femoral neck and lumbar spine in the back. So both vegans and vegetarians, but they said only vegans had higher fracture risk. And they say vegetarian and vegan diets should be planned to avoid negative consequences on bone health, they say. And then one of the articles included here, it was from an EPIC Oxford study. They claimed that they had made some errors in the first analysis and said that we don't think that vegetarians have increased risk of osteoporosis, but they agree that vegans, that's a group which should be focused on. Yes, and then it's quite popular to take high doses of vitamin supplements. And you can buy it on the internet, and this is a new thing that you can sit in Norway and purchase high-dose vitamin supplements. 30 years ago, you had to go to the pharmacy and you couldn't buy them because it was quite strictly regulated. And then you know that this curve, that too little or too much, is not good. And And when it comes to vitamin D, we know that if you have far too little, you increase the risk of rickets, engelsyke, osteomalacia, and osteoporosis. And then on the other end, you have intoxication and other side effects. And we have visitors from Australia, and you might know this study from Melbourne. They included 2,256 older women, and they were supplemented with a mega dose of vitamin D once a year. And if you divide it on 365, it was a normal dose of vitamin D per day, equivalent to that, but given as a mega dose. And it has been done before to give a mega dose of vitamin D, so that works. So it's not dangerous to give a mega dose. But the hypothesis was that this would prevent the risk of fracture or decrease the risk of fracture. But what they found in this JAMA publication published in 2010, I think, among older community dwelling women, annual oral administration of high-dose vitamin D3 resulted in an increased risk of falls and fracture. So they found an effect, but it was in the opposite way. So it increased the risk. And this is probably due to the physiological thing to give a mega dose, and then the PTH, if you know PTH, parathyroid hormone, it decreased a lot, and then it decreased again. So it was not a good strategy, but it increased the risk of fracture. And a similar British study found exactly the same for hip fracture. So it's not a smart idea to give these mega doses. Of course, if you work in a hospital and you have an old person coming in with extremely low concentration vitamin D, you might still give it, but that's in a clinical situation. But if out in the community, you should avoid it. And then we made a few studies on B vitamins, and too much vitamin B can cause hip fracture. And this is, they performed 2 large randomized controlled trials in Norway around 20 years ago to see if they could prevent cardiovascular disease by supplementing with high doses of B6, B12, and folic acid. It was a no-risk or Venbit study. It was around 7,000 people included, double-blinded study. And then we knew that the high concentration of homocysteine is associated with increased fracture risk. So we thought, well, if we reuse this data and link it to hip fractures, we will see what we find. And our hypothesis was that high intake would decrease risk of fracture. But what we found, to our big surprise, was that those giving B12 and folic acid, it was a bit difficult, but it was a factorial design, meaning that there were 2 interventions at the same time, so you could study 2 different interventions. So those in the intervention with B12 and folic acid, no association with hip fracture. Whereas those given B6 versus no B6, they had a significantly increased risk of hip fracture, 42% increased risk, and clearly significant. So this was a bit shocking. And but these doses of B6 they were far higher than you can achieve in diet. So it was supplements. It was like, I don't recall precisely, but let's say 40, 50 times recommended intake. And then we made a similar analysis in a nurses' health study in the US. It's a cohort study, and we found the same thing. These results add to the evidence suggesting that caution should be used in vitamin supplementation where there is no apparent deficiency. And even Scientific American, they wrote an article, and the author said, what did she say? More than half of American adults take vitamins pills. I've watched in wonder as some of my more health-conscious friends kick off their morning with an impressive array of multicolored supplements. So it's not a good idea. Okay, conclusion. I think we are. What's the time now? It's. Yes, it's fine. Yes. So my first point is avoid undernutrition. And undernutrition, a low body weight, is very important in the very elderly, at least. So avoid under nutrition, because then you could prevent weight loss, and you could prevent frank deficiencies of vitamins, minerals, etc. In general. And then when it comes to vitamin D and calcium, we suggest that you should adhere to the official recommendations. And perhaps we talk about vitamin D and calcium is what you also say prescribed to patients when they take active osteoporosis medication. So you should secure recommended intake of vitamin D and calcium before you start giving them active medications. And then I think we will hear about proteins later on, so I have not focused on that, but I can just say that when it comes to proteins, I don't think that eating a lot of proteins will help you, but I think that eating too little protein could be harmful. So it's more about not eating too little, but sufficient. And I think the idea that eating more and more of vitamins or proteins or calcium or everything, that's not the point, but the point is avoid to get too little. Yes. And then eat recommended healthy diet. It's nice that, for example, the Mediterranean diet seems to be good for your bones too, it's great. For elderly with a low food intake, then of course the recommended intake, you're aware of it, think differently from what you advise the general population. Perhaps they need to take the vitamin supplement, need to have some more energy in order to get enough. Okay, then I think that's my last slide.
Yet, because maybe questions. So, have you? See, we already have a few questions here. See, yes, we have a question. For the help. Thank you. It's for the followers. So please name and where.
My name is Marianne. I'm from Tine. And thank you for a nice or very interesting talk, Haakon. I'm hearing your thoughts about vitamin K and especially the K2. We the ferment dairy products. We have some interesting studies way in the what do you think about vitamin K and bone?
Yeah, so if I referred to it to start with in Lancet, then they also discuss vitamin K, and it's promising. I think that I guess is that again not too little, but it's interesting, and K2 and actually for many years ago we didn't. There were studies, and there could also be an interaction with vitamin D suggested. So it's interesting, and it has in bone tissue, so it's plausible that it could have an effect also. Yeah.
Since I have the microphone, I'll ask you a question too.
The power of the mic.
Yes, the power of the microphone. Maybe you could say two things. How's the osteoporosis going? Is it going up? I mean, we talk about the hidden women disease, I heard it's been called. So has it been going up over years?
Yes, so thank you for, it's a good question. And actually the incidence of the most, what we claim is to be the most important type of fracture, hip fracture, is going down. And it has been going down for many years. However, they are becoming more elderly, so we predict that the number of hip fracture will increase in the future. So until now, for example, the last 20 years, the number of people 80 years plus in the Norwegian population has been quite stable. It has not increased, but now it starts increasing. And you know, the birth cohorts before the war was much lower than after the war. It was a difference of 20,000 per year. And so now the baby boomers are becoming old. And this effect is, you see it in many places, but it's quite strong in Norway. And now those born in 1943, they're turning 80 this year. So it will increase a lot the next years. And then you need to prevent a lot of fracture in order to not increase the number of fracture we have to treat at hospitals. But it seems to be, if you adjust for age and look at the risk of having a hip fracture for women 80 years, it's lower than it used to be.
But because we would be concerned, since we are working on milk, the milk consumption has gone down for a very, very long time, right? So we drink much less milk, especially also the young girls, which is important to build the calcium or the bone. Are you concerned about it? Is it just us?
No, as I said, that I'm in general, osteoporosis is not a calcium deficiency disease. That's not a problem. But of course, if you get too little, then it's a problem. But it's not like if you just increase, then you fix the problem. It's not like that. I think that milk and dairy product is important because it provides some calcium, but it also provides a lot of other things. And in order to avoid too little of different constituents in diet, I think it could be an important part.
Good. So I will give you a question from the digital Slido. Is there any difference taking calcium or vitamin D through food or through vitamins pills?
Yes. So when it comes to calcium, then there has been a discussion because some researchers they reanalyzed data from trials and they claimed that calcium supplementation could increase the risk of cardiovascular disease. And it's quite debated, and they don't agree about it. But Ian Reid, which I refer to him on BMI, he says that, but he's coming from New Zealand, and the largest export industry in New Zealand is dairy products. But what he says is that if calcium is provided in dairy product, then you get a quite slow increase in serum calcium, which is beneficial, he says. That would also be the sake if you take a supplement together with food. However, if you take a supplement on empty stomach, then you will get a sharp increase in serum calcium, which could potentially be a problem. So it's recommended. So if you look at official recommendation now, it used to be take a supplement. If you don't have enough in the food, take a supplement. Now it's more try to eat calcium-rich food and then add on with half of it as a supplement. And they try to push people to eat more calcium and not only taking supplements, just to be on the safe side of the road. And for vitamin D, we made a study actually where we compared the intake from multivitamin tablets and fish oil. Vitamin D is the same amount, and what we measured the concentration blood sample, it was exactly the same. So probably it's not that important. We thought that if it was in a fat-soluble environment, it would be better, but it was the same.
Any questions from the room? I will take one from Slido while you think. Do I see a hand? No? So if you're a woman, midlife, starting to be concerned about your health and with a wish to prevent osteoporosis, what should she do?
Don't become too slim. I think it's quite important because it's actually you have a calculator for fracture risk. You can either use BMI or bone mineral density, and the results are quite similar. So it is quite a strong risk factor. So I think to have a stable and as I quoted here, the aim is not to have a high BMI, but to avoid a low BMI. And weight loss is also a problem. And then, of course, eat an overall healthy diet, and to have a recommended intake of things is a good thing, of the different things I talked about.
One more question here. I'm trying to translate, that's why I'm looking into this. Which one of the risk factors for osteoporosis can you actually affect? You cannot change your age, you cannot change your sex, but what can you do something with?
Yes, and it's back to to body weight, and physical activity is important. And activity is just as important for fall prevention as for bone density. So, but for both, it's important. So, physical activity and diet, and then do not drink too much. It's also a good advice. And then do not smoke. It's a good advice. And then, of course, if you have a low energy fracture, which is you fall, let's say you fall out in the street, and 10 years ago you would not have a fracture, now suddenly you have a fracture, then you should have a bone scan or go to the doctor, ask for a bone scan. And if you have a mother or a father with fractures at younger age, in low energy fracture, then that could also be a signal, because it's also related to your family history, the risk of fracture. So because there are treatments options in addition to what I've been talking about, so osteoporosis treatment.
I have a question.
Yeah.
Can you compensate low BMI with working out a lot? Like, will that?
So if you have a weight-bearing activity, that will stimulate stimulate bone tissue.
So lifting
but
weights.
it's a fresh. You have to do it all. I mean, if you do it now and then sit down for next year, it will not help you. So you have to be active. It's a ferskvare. It's ferskvare, as we usually say concerning physical activity. So, but it's important, definitely.
Okay, good. So last chance. Any questions? Okay, good. So thank you so much. I think there's a small gift for you. Oh, it's not so small even, it's quite big. And I think it contains dairy products.
Okay. Oh, yes.
So a hand to Haakon Meyer. Thank you so much. So the next speaker we have up on stage is Anne Thorbergsen. She's a clinical nutrition physiologist. She also has a PhD in what we're talking about today, nutritional risk assessment for hip fracture. You did that 20 years after Haakon Meyer,
Yeah,
and I think it's related to his PhD
well,
even.
yeah.
You told me. You work in Nutricia Advanced Medical Nutrition,
Yes.
which is a company developing enriched products for people whose ordinary diet is not sufficient. And the topic for your mini lecture today is sarcopenia in the elderly. You have 25 minutes, and please remember to think of the questions afterwards. The floor is yours. Give her a hand.
Yeah. Thank you very much. I'm happy to be invited to this talk, this topic of sarcopenia in the elderly. But I really also have to talk about malnutrition and talk about the impact it has on the patient and also on the society. So my disclosures are, as you all heard, I work at Nutrition, but I also have done a PhD. And I really, this is what my topic is going to be all around, highlighting some of the key take-home messages, really. So why do I talk about malnutrition when I'm going to talk about sarcopenia? And the reason why, really, is because the two go so closely hand in hand that you can't really separate the two. So if you're going to treat a malnourished patient, you also have to take care of the muscle mass of the patient. And I'm also going to introduce to you, if you don't already know, the topic of sarcopenia obesity, which I think it's really not recognized. As you heard earlier, everyone knows that low BMI is what is causing increased risk of hip fracture. But what about these overweight with low muscle mass patients? What about them? So I will start with the malnutrition before I go into sarcopenia and what to do. So when I was saying I have a PhD in risk of hip fracture, and I'm not going to tell you in details what we did and what we found, but I'm wanting to highlight some of the key take-home messages showing you this. It's not much on this slide. We included just over 300 patients. They were 8 years old, just above. But what about BMI? Anyone wants to guess? Was the BMI high or low? Anyone raise their hands for high BMI? No? Not high. Everyone believes it's less than 20. No, not everyone. Somebody's shaking their heads. Think about it at home as well. What do you think? And this is the truth. I was really surprised when I saw this. I mean, you have a BMI of the patients, hip fracture patients, of 24. You see the deviation is big here, it's large. But it means that we have patients here being both normal and overweight and obese in this cohort of patients. Yes, it's true that when you look at comparing these patients with ordinary home-dwelling patients not sustaining a hip fracture, BMI was lower, yes, but it wasn't really that low. And then we really wanted to see, I want to go back, because when I looked through the journal of all these patients, 300 hip fracture patients, I was looking for the diagnosis, the ICD-10 code for risk of malnutrition or malnourished patients, and there were 0. 0 patients were at risk of malnutrition. And I thought, this cannot be, this cannot be. So we were looking into the vitamin concentrations in serum to see maybe there is a link, and yes, there was. But it wasn't just vitamin D, like we heard about. It was vitamin K, it was vitamin C, it was vitamin E and A. And this was all independent of BMI. This means that when you're facing a patient, you cannot tell if a patient is malnourished, whether there is an obese or an overweight or a very thin, slim patient. You cannot tell whether there is a risk of malnutrition. So therefore, you really have to screen. And if you look at these numbers from 21 from the Director of Health, only 18 home-dwelling patients were actually being screened. So if you're not looking for malnutrition, you cannot state that, oh yeah, we do not have malnourishment in our ward or in our community center or in our county. You know, you have to screen, otherwise you will not know. And the Director of Health says, well, they state that all patients must be screened. And why is that? And really it's because risk of malnutrition is related to an increased burden of the illness of these patients. And not only does it, well, it causes complications. And when you have complications, you have a worsened rehabilitation, which makes perhaps you have to go back into hospital, readmission. And you have less physical performance and also mental capacity. When you have low physical performance, you might fall again, have a new fracture going back. When you're having a hip fracture, I mean, maybe all of you have, or at least most of you have, maybe a father or a mother or a relative grandmother, father, who sustained a major injury, becoming delirious. All of a sudden doesn't know where they are, doesn't know, they see big spiders flying, they become really scared, shouting, being really afraid, subdued. This is delirium. And we called it acute earlier. Now it is acute, but what happens is that this is the trigger, this is the onset of dementia or cognitive decline. So that's really an association that we don't want to have. And quality of life, if you can't get back to the life you were living before you had the fracture or the injury or whatever happened, illness, you will have a reduced quality of life as well. And you see in some diseases, like for instance cancer, you will see that you will have to have delays in your treatment. You will have to reduce the dose of chemotherapy giving, or maybe even stop the treatment, because the patient are becoming malnourished. And this will give you a shorter life expectancy. So who do we really treat then? I mean, it's so easy to look at this blue person and think, yeah, here we have a malnourished patient, we need to do something. But the thing is, like I was showing you in my hip fracture data, the obese patient might be malnourished as well. And it's also looking into that is this obese patient, when they are losing weight, unwillingly, you will not detect it. It will just go on, it will carry on, and maybe you don't detect this patient before you become the blue one. And it's so much easier actually to prevent people losing weight than actually doing something to sort of gaining weight again. So it's really, you have to watch out for these, for everyone really, and that's why you need to screen. I wanted to show you this. This is 3 different people with different BMIs. You have an underweight to overweight patient, but what you see, if you look at that obese patient, the amount of muscle mass, the blue, is similar to a very malnourished, underweight patient. So this is when it becomes really a little bit scary. If you're overweight and you have so little muscle mass, there is no wonder why this patient is having difficulties rising from a chair, or walking a distance, or climbing the stairs. This is sarcopenia. This is loss of muscle mass. Happens in everyone. And this is circle of circle of life, a circle of muscle mass and function, because early life is really all about increasing your muscle mass and reaching a peak. And in adult life, you try to maintain and sustain that muscle mass and strength and function. And in the older elderly patients, it's all people. It's about not declining your muscle strength. And there's a large gap between patients or people, but it's all about trying to keep above a threshold of physical performance and disability. So what does cause this loss of muscle mass then? And aging, I was saying over time, yes, it's with age you will decline in muscle mass. And disease, inflammation, it's a reaction. It's something that starts happening in your body, will break down your muscle mass to provide the energy, to provide the protein. So when you're having an inflammation, it can be hip fracture, will increase CRP. You can go from sort of below 10 to above 300 in just a few days. And even though it does come down after a few days, you will see it maintains high for up to a year. So disease will increase your loss of muscle mass. And inactivity, like Haakon was saying earlier, was the weight-bearing activity. You really need to be active to use your muscles in order to not only build bone, but also to build muscles. And malnutrition. It's obvious if you're not eating enough, or if you have malabsorption, you can't really utilize the nutrients you're eating, that will influence muscle mass. But also obesity, that's the last point here, overnutrition or obesity. And why is that increasing the risk of losing muscle mass? It's really because if you have become overweight, well, I shouldn't say this for sure, but one of the hypotheses and theories is that you will then also be more inactive or less active. So watch out also for obesity. And I wanted to dwell a little bit on this one. It's a CT scan of an obese patient at the bottom there, and a lean patient. It's taken through the thighs. So it's 2 legs at the top and 2 legs at the bottom. And what you can see here in the lean patient has very little subcutaneous fat, the yellow there. But what you can also see is that actually the muscle mass is bigger than the obese patient. You see the blue big bulk of muscle in the thighs. It's an important muscle in people. But what you can also see in the obese patient is by red, you have all this fat infiltrated in the muscle mass, which makes the muscle less dense, and you will have a lot less muscle quality and in the obese patient. But I guess, because we're having a milk seminar, now I guess all of you have already spotted the pink middle. It's the bone, it's the thigh bone being pink, and in the lean patient is actually greater than the obese patient. And this is what Haakon was talking about. You have to have your muscle mass building, working on the bone mass all the time in order to obtain a good bone mass. So this is why it's so important to think about loss of muscle mass. So how do we set the diagnosis? And one thing is to assess the muscle strength. You can do it by a hand dynamometer, or you can measure muscle quality and quantity, and you can do that by DEXA scan or a CT scan, or physical performance. You can make these tests of chair stand test and walking distances and so. But it's like, I guess all of you are thinking, this is really comprehensive. Should we do this in all our patients? As a scientist, I would say yes. But as a clinician, I'm thinking maybe it's hard. But at least be aware. You know, if you have a patient that is telling you that, oh yeah, I'm feeling weak, I'm falling a lot, or you can even see it if they're walking into your practice room, or you see it in the nursing home. You can see that there's patients really struggling walking or rising from a chair. You should suspect that this is loss of muscle mass. There is something going on here. And then you should start to think about weight loss and screen these patients. But before you do anything, really screen for loss of muscle mass. And there's this SARC-F screening form that has been recommended by a lot of people around the world now. And it's really a questionnaire that patients can fill in themselves as well. But if healthcare professionals are doing it, that's really good. But it's really just asking the patients about the strength. Are you having difficulties lifting 5 kilos? It's asking about walking. Are you able to walk without assistance, or how do you do? Is it a problem? It's rising from a chair. It is climbing stairs and falls. Asking the number of times you have fallen over the last year. So it's really an easy questionnaire to follow, and if you score more than 4 points, you are at risk, and you should examine further. So a thing to do, and we actually did it when we did our research, when we did our study. We measured hand grip strength, and we measured it first when the patients and the controls without the fracture. We measured it when they came into hospital. The patient when they came into hospital, to see what is the strength, what is the hand grip strength of these people. And I can tell you straight away, well, we had a baseline of 23, and this was lower in the patients than in the controls, significantly. But what you see in the top of this slide is that these patients, when we measured them again 4 months after the fracture, they had actually lost weight. And it didn't matter whether they were, because in the patients, half of them got an intervention, which was nutritional advice. We used the recommendation, all the leaflets from the Director of Health, and we gave them supplements. They were carrying bags of vitamin D and K and calcium supplements together with cod liver oil, because we really believed that we were going to get improved nutritional status in these patients. And we did as well. We could measure after 4 months that the vitamin concentrations, I told you they were low, but the vitamin concentrations had risen. And that was good. But when we looked at this, what do you reckon? These patients, when they are lying in bed, just had hip fracture surgery, and we were asking them to really clamp as hard as you can onto this hand grip dynamometer. And then when we measured again, there was a nurse traveling around Oslo region to visit these patients again, measuring it again with the same hand dynamometer. And what do you reckon? 4 months later, had they rehabilitated to increase their muscle strength? I hope you're all shaking your hands. And this, I thought, I didn't know that they had lost 5 kilo when we were doing this. So I really thought, you know, when they rehabilitated after 4 months, they must be better. They must have improved, right? But I was wrong. They had declined. And this is together with the fact, you know, that they've lost body weight. And when you're losing body weight, you're also losing muscle mass. So even though we managed to increase the nutritional status in terms of vitamins, I'm really, it's like, yes, they did manage to increase their vitamin status because they had the vitamins supplied to them, but we only gave nutritional advice. So if you want them to actually sustain their body weight and muscle mass, you have to provide the food. We have to start giving the patients food. We can't just give them a supplement and think that everything's fine. Because if you lose your muscle mass, you will trip over your cat and fall again and be readmitted to hospital, causing you a lot of problem as a patient, but also the society will have to pay for it. So what do we do? If you have a robust individual who's just have a pneumonia, you will have what we call an acute catabolic response, and you will decrease your function and your muscle mass. But what a robust person will do is that when you have finished your pneumonia, you will climb back to your baseline sort of muscle function and muscle mass. You're seeing it does decline. It will decline with age. But when you have a malnourished and frail elderly patient sustaining the same pneumonia, you have the catabolic crisis, function decreases, and when you climb back up again, you won't get to your baseline. You will get maybe just half the way up. And then along the line, if you have another pneumonia, you will have a new catabolic crisis, and function will go down, and you will recover, but not to your baseline. So this is how sort of a disease after disease will accelerate loss of function, muscle mass. So really, what do? Well, we have to treat these patients. We really need to try with nutrition and physical activity to get them back on track. Make sure, like Haakon was saying all the time, make sure they don't become malnourished. So there is a screening tool now recommended for all patients, whether it's hospital or if it's nursing homes or home-dwelling patients, to screen using the malnutrition screening tool, MST. And it's really easy. It's only 2 questions. And the first one is, have the patient lost weight recently? And the other one is, have the patient ate less than compared to normal intake? So it's really easy to screen and look for it. But when the patient is screened, you really have to do something. And then the director of health are recommending the staircase, and maybe some of you see that the first step I just put underneath, like the baseline, you have to treat the condition. You really have to treat the disease and the symptoms of the disease. But then first step is really look at the environment. Is it the social setting correct? Is it fresh air, and so on? And then you have food. What food is being given? Is the food likable? Do they like it? Is the portion size huge, or is it? Can we do something to adjust it? But then it's really fortify food and use in between meals. Maybe it's better to have smaller portion sizes and maybe give more enriched food and food more often. And if you can't reach your goal, if the patient is still losing weight, giving fortified food with ordinary food, then you have to move up the food chain and start using supplements or oral nutritional supplements. And this is different from vitamin supplements that we had talked about earlier, because it's still food. It's still energy, it's still protein. And if that is not enough, you move further up and do tube nutrition or even parenteral nutrition. And it's easy it's important to recognize that you can move up and down this ladder. You can use fortifying food with milk or cheese and butter or egg, whatever, and you can also do ONS, maybe for a short while, and then go back and just maintain what the patient is being given, but keep watch of the weight. Because when you are losing weight, you're also losing muscle mass. So yeah, I was saying, I put this as the base, and then I built onto this one. And this is because all the papers you read, when you're given nutrition to make sure they're not malnourished, you also have to do physical activity. And then again, there's a lot of papers out now, treat the nutritional impact symptoms. Find out why is this patient not eating. Is it nausea, vomiting, diarrhea, constipation? And really, you have to take into account these measures to try and adjust. And then the last slide really is health economics. I was saying to you that these patients, they rehabilitate less quick. And that means they have a longer hospital stay. You know, when you're in hospital, you have the cost of the medical doctor, you have the cost of the nurse, you have the cost of all the apparatus in the ward. So every day you stay in hospital costs money. And if you then also have more readmissions because you're malnourished, then you will have more hospital stays costing money. And these patients are also more frequently admitted to ICU, the critical care unit, which is the most expensive ward in the hospital. So a malnourished patient costs about 3 times more to treat than a well-nourished patient. So key take home, screen all your patients for malnutrition, assess the risk of sarcopenia, also in overweight and obese patients, and initiate individual measures based on your assessment. So just remember that Einstein was saying that everyone's responsibility, well, everyone's problem is nobody's responsibility. So make sure it's your problem and it is your responsibility to do something. Thank you so much.
Thank you so much, Anne. I see you're getting good at Slido now because the questions are coming in. Are there any questions from the room first? Anyone who wants to do it the old-fashioned way? No? No? When we open up for this, nobody dares to raise their hand. Okay, so a few questions that I missed for Haakon Meyer. Maybe you can answer them. If not, just...
Or maybe I can hand them over to
Yeah,
Haakon
you can
as
also
well.
hand them over. In Norway, there is a high frequency of osteoporosis compared to the rest of the world. And some people seem to think that this is because we drink too much milk.
Yeah, well, I don't think so. And Haakon is shaking his head as well. I was looking into this when I was doing my PhD, and I was looking into how much are we actually eating. And when you look at Europe, when they're having, for every meal, they have it's not a pudding or a dessert, but they have cheese very often. Like look at France, they eat a lot of cheese. And they don't have a high rate of hip fracture anyway. So I don't really think that we are having too much. No, I don't know.
Do you want to add something, Haakon? You have to use the mic.
Yeah.
Yes,
Good.
so it's also interesting, we didn't talk about, but also some studies suggesting that fermented dairy product could be even better for your bones. So it's some discussion, and it could be K2 and a lot of things. But and of course that could be different in Norway and France, for example. So, but we did the extensive analysis in Norwegian data, and we didn't find that high intake was associated with increased risk of fracture in the Norwegian populations. So I don't think it's any reason to believe that a high dairy intake is responsible for high fracture rates.
No, I agree.
Okay,
Yeah.
so you agree? Okay, so next question. Many elderly receives different equipment to help them in the home. Is this good or bad for them? For example, a chair with a function that helps them getting up?
Mm-hmm. Well, in my opinion, like I was saying, you really have to have the physical activity. And it may be in a situation where just after, for instance, a hip fracture, that you need some aid or assistance. You have these chairs, you have a remote control, and you're sitting in the chair, and you don't have to use one single muscle, because maybe you have the walking aid in front of you, And all you have to do is push the button, and then you climb onto the walking aid, and you are up and walking. And by doing that, you're not really using your muscles. So maybe for the first few weeks, until you're able to stand from a chair, it could be good. But after that, take it away. I mean, I've seen a lot of hip fracture patients. I was saying we visited these patients 4 months after the fracture, and a lot of them still have these aids of enabling them to rise from a chair. But actually that exercise, and say, yeah, they have to exercise, but that can be enough, just rising from the chair every day. It could be, and maybe being conscious about it as well. Maybe rise from the chair as many times as you can, just to see how many can I do. And maybe even start writing it down, and maybe your next of kin can ask you, how many times have you done it today? And make that your exercise, perhaps.
Good. Okay. I'm trying to translate this. Would you say that overweight people har noe å gå på?
Yeah.
That it's okay that they lose weight?
No.
Or if they should try to keep their BMI?
Try to keep your BMI. Well, I mean, there's a lot of, depending on your situation, if you're really obese and you're having a heart failure issue, maybe you should try and decrease your body weight. But if you're doing that, please look after your muscle mass and your bone mass as well. Make sure you do it together with physical activity. Make sure you're active. I don't really, maybe you have some more data, or you have some more data to talk about it, but in my opinion, keep your body weight.
Okay, so last question I have here is how much is genes? How much does it affect the risk of osteoporosis?
Well, there is a risk, and Haakon was talking about that there is this risk assessment form, and in this form there's a calculator basically, and you can, in this form there you put in if you're having family history with hip fracture, and that will increase your risk. So there is a genetic component in risk of hip fracture. But when that is said, it's like the question earlier on was, what can you do yourself? Because you are born with a set of genes, and it's very hard to change them. But if it's so or so, you really have to try and do your best, and try, like Haakon was saying, don't become too thin. But I will also add to that and say, look after your muscle mass.
Okay, one more question here. Is a hip fracture related to muscle mass, and is that independent of your BMI?
Probably. We didn't look into that in our study, but there is, for sure, low muscle mass will increase risk of falling, and then you will also have a risk of fracture. So, but I wish we actually, because we had all the data, and it's stupid we didn't look into it, but I wish we did, but I believe yes.
Last chance. Oh, yep. The one with the microphone.
And just want to say that if you want to ask in Norwegian, we can translate.
Yeah,
Maybe
sure.
somebody feels,
I'm sorry, I forgot to say
a little
that.
bit of. But I just want to ask Haakon Meyer, maybe you could, because what do you think when you're here? Because I hear from you that you said, be aware that we do not lose too much weight, which I'm glad to hear, personally. But at the same time, you say, okay, you have to be aware. You have to look at also the other side. So, do you have any comments to what Anne is saying?
So I think that when it comes to body weight, then we should have a comprehensive view on it. And of course, and if you have a patient, you could think about diabetes, heart disease, all these things. So and then for some of these conditions, you would prefer them to perhaps lose weight. But I agree, you should be careful with muscle mass and exercise, all these things. But as I referred to, quoted that you should. Try not to lose weight, not too much weight, but of course, if you are in a very upper range, then that situation could be different. So, yeah, and then when it comes to fracture, then it depends on hip fracture. It's quite clear, but for some other types of fracture, then there is an increased risk in those with a high BMI, for example, forearm fracture and ankle fracture. So the pattern is a bit complex, but still I think that to maintain a healthy weight, we should aim for that. And of course, if in elderly people, then studies have shown that the healthy weight is, the lowest mortality is found at a higher weight in the elderly compared to the younger part of the population. So,
Yeah, I agree, and a lot of studies show that a BMI of 25 in these patients is optimal, and this was actually 24, so they did have a low BMI. I just didn't think when I was doing the study that this was low BMI.
But could I also comment, because if you just look at the mean, because I think that the difference of 2 units in BMI is quite a lot, and then you have to look at distribution. So I'm sure that those with a very low BMI was quite much larger in those with hip fracture compared to those without hip fracture. And also, if you have a BMI of 22, you actually have a high risk compared to 25. So,
could be.
Yeah. So it's a gradual, but
probably. But what my worry is, when you were talking about earlier on, that there is because you were asking how about hip fracture rate? Is it inclining or decreasing, or what? Is it stable? And you were saying per now is actually maybe lower than it was maybe 10, 20 years ago. I don't know. But I am worried about those becoming elderly now, because I don't really think that they will be as malnourished as the hip fracture population that we used to be looking at. Because I believe that a lot of the elderly becoming elderly now, like the baby boom you were talking about, becoming elderly now, they might not be so malnourished to look at. I'm worried that a lot of them are overweight and maybe even obese. There's a lot of cake and easy access, high energy foods, and you're sitting there maybe being alone and not being so physically active. I'm worried. This is just a worry. I have no data to support this, but I'm worried that the elderly population might struggle, if not more, at least as much, even if they're looking more healthy.
Okay, so thank you. Give a hand to Anne Torbergsen. And thank you so much for your participation with your questions. It's very important, I think, to the program. So last but not least, now our international guests coming all the way from Australia. Sandra Giuliano will come up to the stage. Thank you so much. Sandra Giuliano is a researcher at the University of Melbourne, based at Austin Health. Her work focuses on the benefits of improved nutrition on falls and fracture risk in the elderly, especially those in aged care. So you also have 25 minutes, and the name of your lecture, I think, is behind me, Preventing Fractures, Falls and Malnutrition, Results of a Dairy Intervention Trial for Older People in Residential Care. So again, I remind you, use the Slido or your hand afterwards. And thank you so much for being here with us. I know you're kind of on a tour all the way all over Europe, and you're really eager for your studies to be implemented. So please give her a hand. The floor is yours.
Thank you. And firstly, thank you for doing it in English. I know it may not be easy for everybody to be interpreting what I'm saying. So as before, if there is a question and you need to ask it in Norwegian, please do, because the value of this work and the value of what I'm talking about is only of value if you're gaining something from it. So please feel free to ask questions, and also for the audience that are watching virtually. So as always, these are my disclosures. So we've spoken a lot about hip fractures, and we know that the burden of fractures is quite large, and it's getting larger because globally we're ageing. So I'll present some data on hip fractures, but the longer we keep people alive for, the greater their risk of fracturing, simply because of their age. So while the discussion has mentioned that rates may be lower, which they are, the sheer number of people in that older group will increase the burden. What we also know is that when people are in aged care, so in a nursing home or residential care, their risks are much higher. So the data from Denmark shows that you have quite a large proportion of older adults in care, and that number, as far as I could find, was somewhat lower in Norway. And in Australia, it is around 6%. But with that 6%, if we look at all the hip fractures that occur in older adults, 30% come from that small group of people. So their risks are extremely high and much higher than aged matched people in the community. So the hip fracture burden will be quite large in Europe, and we know, for example, in Norway, it will increase as well. So this is a beautiful segue to both our prior speakers. Yes, the rates of hip fractures are declining in Norway. And they've done some work that actually looked at why it's declining. And yes, part of the reason why is because of that increase in BMI. Also, interestingly, more hip replacements, greater use of osteoporotic medication, more physical activity, and from a decline in smoking and a decline in medications for insomnia and for anxiety, so those that can affect balance. So the most recent data I could find in Norway and in Denmark, where the hip fractures are just under 10,000. As I mentioned, as the population goes older, despite that decrease in rate of fractures, the sheer number of fractures will go up, and it's going up globally. So the problem is occurring, and in actual fact, it's occurring almost exponentially in countries that are second and third world, because now we're getting people that are living at an older age, but with perhaps not as good nutrition. Again, when we look at people in aged care, so in nursing homes, their rates of falls are about 5 times higher than people in the community. And I found some data from Norway, and it was around 3 times higher. So if I took a person in a home, their rate of falls are 3 times higher than the same age person in the community. This is often because they go to the aged care home because they're falling. So it's not that there's anything particular about the home, it's just that they are at high risk. And the rates of falls in older adults is quite high in Norway, and unfortunately one of the leaders in Europe, 19%, so nearly 1 in 5 older adult falls, and in Denmark it's slightly lower. But when we look in aged care itself, between 30 and 60% of the residents fall. So if you imagine I have a facility and I have 100 people in that aged care home, 60 of them are going to fall in a year. And again, back to fractures. So there are 2 times in the lifespan that fractures occur. One is during growth, adolescence, and the second is that exponential increase in old age. Now, as I mentioned, as the population gets older, you can see the risk increases. So it's the sheer age of the population which is going to contribute to this risk. And with that comes a cost. Now, the cost is one to the person, because often within 6 months that person has passed away. It's like quality of life, but there's also a substantial cost to the healthcare system, but also to the residential aged care home. When they go back to that home, they require more supervision. They require maybe lifts in order to be able to be moved around. So in a sense, the responsibility isn't just the health system, isn't just the aged care home, the responsibility is both. So when we look at these older adults in aged care, we know that 30% of the hip fractures come from that group alone. We know that they have high rates of falls. They have extremely high rates of malnutrition. So in our group, 68% of residents were malnourished or at risk of malnutrition, so that's over 2/3. Their calcium intake is low, and that's a feature that is going to be contributing to their risk of fracturing. And in Australia, that's less than half of what is recommended. Their protein intake is low. It's around 0.8 grams per kilogram body weight. And again, if there's insufficient protein, they're not able to maintain muscle. And from that, the outcome we were looking for were fractures. The main food that provides both calcium and protein, amongst other nutrients, were dairy foods. And we looked at what they were consuming, and they were consuming between 1 and 1.5 servings per day, in contrast to our recommendations, which is 4, so substantially lower. Now, I'm a nutritionist, and I am adamant about food-based approaches, because we know from the data that long-term use of supplements does not work. Oral nutritional supplements work in the immediate time, post-hospital discharge. They can work and are very effective in improving weight for a limited period of time, but the data demonstrates it's not a long-term solution. So I simply asked the question, if I improved their calcium and protein intake using a food that they know, that is familiar to them, would it reduce their risk of fracturing? So the trial was extremely large, and looking back, I wonder what I was thinking when I started it. But we had 60 residential aged care homes, and what we tried to do is get small ones, 50 beds and under, medium, 50 to 100 beds, large. We had those that work in aged care that have their food service within the facility. We had some that use catering. We use non-for-profit organisations. We use for-profit. We had them in the cities. We had them in the rural areas. So we really tried to capture the variety of homes so that this type of method could be done elsewhere. So 30 of them were randomised to increase their dairy content of their menu, and the remaining 30 went about their usual food. We followed all the residents for 2 years. So we fed 3,500 older adults for 2 years with the additional dairy food. And in a small subsample, we did more extensive testing. We did bone mineral density, we did other assessments, serum, etc. So if we saw something, we could actually have the mechanisms why were these changes actually occurring. So the study design is simple in theory, and it's practical. All we did was help the chefs and cooks to increase the variations of milk, yogurt and cheese on the menu. So if, for example, the residents preferred more cheese, we used more cheese. If they don't use yogurt or don't like yogurt, we didn't use yogurt, we used more milk cheese. So the differences were very much based on how the chef wanted to cook and what the residents like to eat. And that is critical, because if they don't like it, they're not going to eat it. If they don't eat it, there's no value to them in terms of the extra nutritional quality. So we added various dairy foods to the menus. We fortified the milk with skim milk powder, and I often get asked why skim milk powder, not regular milk powder, because there's more protein and nutrients in the skim milk powder. We substituted, so we know often with texture modified food, we use gravy to lubricate the food. So in place of gravy, we might use a cheese sauce or a white sauce. And we modified recipes. Older adults love desserts, and often the desserts contain almost no nutritional value. So by providing desserts that they enjoy that were high nutritional value, we were able to improve their nutrient intake. So this is the demographics of the sample, and I've done that on purpose so you can see that they're extremely old. But what I really highlight here is this is their vitamin D, their serum, and as you can see, they're extremely replete. This trial would not have worked if they were vitamin D deficient. So the vitamin D is critical when we are looking at an intervention in an aged care home or in the community. It's critical that their vitamin D levels are improved to adequacy before you may see an effect. Now, in Australia, our foods are not fortified with vitamin D, so our intake is near minimal. And as you know, who has been to Australia, we have ample sunlight, and we assume that everyone gets enough vitamin D. But we know from our data that in aged care homes, they are vitamin D deficient. So before we see the outcomes, I think it is more important to look at the intake. So what we were able to achieve, and remember, this is for all the residents. This is not just selecting residents, and the purpose of it was to stop any decline. So this is the data here. So this is their dairy servings. This is our controls in blue. And you can see that our intervention went up to around 3.5 servings, and it was maintained for 2 years. That is critical. If people do not comply with their medication or with this, a food intervention, you will not get a benefit. So the benefit only comes with compliance, and we know that with osteoporosis medications. When people don't consume their medication in sufficient amounts, they might as well not be taking it because the benefits are lost. So what we observed is that dietary calcium went up to around 1,100 milligrams, again maintained for the entire period. Protein intake achieved an average of 1.1 gram per kilogram body weight. So that's above Australian recommendations, not quite the 1.2 that we were aiming for. Most importantly, energy intake remained unchanged. With older adults, we cannot add more food. From our data, we know that we have less than 2 kilograms of food in total that we can use. That's all they consume. So to gain extra nutritional value, I can't keep adding more food on. So often it was about removing nutritionally poor food and substituting it for, in this case it was dairy food and foods that they know and enjoy. So this is the data. So this is the cumulative probability. So every time a fracture occurs, the line goes up. This is our control group in blue, and this is our intervention in yellow. And as you can see, the line is not as steep, which means less fractures were occurring. And at the end of the trial, we observed 33% fewer fractures just by improving the food quality compared to those that consumed from their regular menu. And I'll show you the data on the bone density. And hip fractures, we can see the line for our controls, and we can see a very reduced line. And we observed 46% fewer hip fractures in this cohort, just consuming foods that they know compared to those consuming the lower quality menus. So we actually did high resolution PQCT, so we actually went one level deeper and were able to really look at bone structure as well. And one of the things that we did observe, I don't have this data, is porosity was reduced compared to the control group. So again, here we're seeing volumetric bone mineral density, about a 2% loss in our controls, which is what we would expect in older adults. In contrast to those consuming the high quality foods, we observed no loss or no statistical loss. So when I look, so I'm very structural. So the scientist comes out in me, there's a practical side, which is how we did it, but the scientist asks, why did it happen? And this is a diagrammatic picture. So this is our intervention group. We know there's porosity because they're old. There's a relative thickness of bone. And what we observed is that with the intervention, the thickness remained about the same. In contrast to our controls, we see that they start off with similar bone, but we can see that more porosity occurs, so the bone is becoming thinner. A thinner bone is a weaker bone. So if that person falls, they're more likely to fracture. And that's what we observed. So all but one of those fractures happened from a fall. So if we stop them falling, we stop them fracturing. And we observed, again, you can see that the line is lower in the intervention group, and we observed an 11% reduction in falls. Now, people say 11%, that's not much, but over 60% of the residents fell, and we observed 23,000 falls in that 2-year period. So an 11% reduction is now 2,000 to 3,000 fewer falls in this group. And as I've got the data there, you can see that mortality remained unchanged. Now, when you speak to older adults, they don't necessarily want to live longer, they want to live better. So we didn't add more years to their life, but what we were able to do is reduce their risk of falling and fracturing, which has negative outcomes to it. And back to the point, so it's interesting that this work has led on beautifully from the first two speakers. So we observed this small 2% reduction, which was significant in weight. Now, in aged care, when there's substantial weight, alarms go off, the dietitian comes in and they try and fix the problem. But this is a small amount over a year. So the weight will not be detected, the loss of weight. But the critical feature is this loss of weight was lean mass of their arms and legs as well as fat mass. So lean mass of the arms and legs is function, how well they get up from a chair, how well they can move around. If they're losing lean mass in the muscles they need for mobility, increased risk of falling, which we observed in our controls. So malnutrition, we use the mini nutrition assessment tool, so I hope you're familiar with that tool. It's there's a variety, 18 questions that give us an indication of their malnutrition risk. And we observed across the entire cohort that the controls lost 1 point on the mini nutrition assessment score, in contrast to the controls that maintained their nutritional status. So you're starting to see this trend here. We maintained bone, we maintained muscle, we maintained weight and nutritional status, which declined in the controls. So when you look at the mini nutrition assessment tool, it categorises people. They're either malnourished, at risk of malnutrition, or normally nourished. So this is the baseline data, and this is the blues are our controls, the yellows are our intervention. And you can see it's a fairly similar distribution of people in malnourished, risk and normal across the two. By 12 months, we can see there are fewer people normally nourished in the control group, and again, more people are becoming malnourished. In contrast, we can see that pretty much they stayed in the categories they were in. And we saw a significant change in categories in that the controls worsened their nutritional status. Now, the majority of fractures that we observed were hip fractures. So 42% of all the fractures we reported, and there were over 300 fractures, were at the hip. And you can see the distribution of the fractures. So this is with aged care residents. And I did find some data from Norway. I did do some searching. And this is fractures that were admitted from nursing homes into hospitals. It's slightly older than our data, but I was quite horrified to see that 70% of admissions to hospital from nursing homes were hip fractures. So hip fractures from nursing homes is a substantial issue. So as I mentioned before, the cost, and unfortunately, often when we talk about quality of life, it draws at our heartstrings, but it doesn't draw at our wallets. But when we talk about the economical costs, then people start to listen that have the ability to make changes. So this is data that I've, from Australia, that I have changed into euro, and sorry, I've tried to be generic, so you'll need to change it to your currency. Hospital has the greatest cost. Then we have rehabilitation. But then, as I mentioned, when we go into the residential aged care home, there is also cost, extra care, etc. This intervention that we did across all these residents cost less than €0.5 per day. So for us, in Australian dollars, it was an average of 66 cents per day per resident. So not an expensive intervention. And our data, which also demonstrate it was cost effective. So we saved money in the cost of reducing the fractures alone by simply improving the food quality. So protein is an issue because the reason we used, as I mentioned, the dairy food is its protein as well as the calcium. Fractures were the outcome that we were looking for. So we looked at what was the distribution of protein across the day in this cohort. We measured food intake every 3 months for the entire 2-year period in about 700 residents. And perhaps similar to here, that breakfast was well below the recommended 20 to 30 grams per day of per meal for protein. Lunch was below, and this was adequate. Now, that was driven by a aged care home that had a lot of Italian people, and I'm Italian and we like our food, and they fed them extremely well. But normally what we'd observe is most of the food is provided in the middle of the day at lunch and less at the tail end. So then, what were the types of foods being provided to these residents? And again, we see that breakfast is often a continental breakfast of cereal, toast, and non-milk-based drinks, juice, or just a plain tea or coffee. The lunch traditionally is meat with vegetables, and we observed that the dessert was non-dairy based, so no nutritional value, and again, non-milk-based drinks. So with dessert, if people work in with older adults in aged care, often they won't eat the main meal, they'll eat the dessert and they'll eat the entree. So if the entree has low protein content and the dessert, that person has missed their protein for that meal completely. And most importantly, with the evening meal, we observed that 75% of the meals, the soup that was provided had minimal protein in it. 75% of the salads had minimal protein in it, and this is often the meal that they're consuming at night. And fortunately, the sandwiches did have some protein in it, but again, just tea and coffee and juice, and the snacks, devoid. Cake, tea and coffee. So here are opportunities within the day that we could be providing more energy-dense and nutrient-dense foods in place of the foods that they were currently receiving. So this is the practical side. How do we do it? How can we actually do this? So when we go to an aged care home or working with older adults in the community, what can we be asking them or telling them or suggesting they do? So for example, to achieve that 20 to 30 grams, in this case, using scrambled eggs, and we added cheese to the eggs, and with the bread, etc., and bacon, if they do consume it, we achieved that level between 25 and 30 grams. At lunchtime, as I mentioned, we used a cheese sauce instead of a gravy, but the dessert, we've used, in this case, a yogurt, or in Australia, they also consume custard, which may not be as common here. But the point is that instead of having low nutrient desserts, we've actually improved the nutritional content, not the volume. It's the same size dessert, just has better quality. And finally, for the supper, something as simple as adding cheese to the soup. This is a quiche with cheese in it, or adding the cheese to the salad. So simple measures we can do, thank you, that can ensure good nutritional quality in the residents. So we're coming up towards the end. The key thing is when we are working with older adults, it's important that we provide options across the entire day. If you looked at the snacks, if I had have just used the snacks as a method to improve the nutritional content, those that don't eat snacks won't benefit. So it's important that there are many options, and speak with the older adults. Find out what they like to eat and provide that accordingly. As I mentioned, if they don't eat snacks, it's not a viable option. So you're using all of this money to provide extra food at snacks, and they're not consuming it. Engage the people. What I eat is not what my mother ate. So it may not be what your grandparents ate. So it's important. Most importantly, those with cognitive impairment can't vocalise what they like to eat. So it's important to ask their family, not what they ate now, but what they ate as children, because that's what they'll be remembering. And understand what the staff, what the food service, the chefs and cook, what they're capable of doing. There's no point in saying that you must cook all the food in the morning and have it in the oven all day waiting if they only have one oven and they need to keep using it. So you need to look at what are the skills of the food service staff and what are the facilities. That was why this project worked. We changed what we did based on the residents and what they like to eat, the chefs and cooks, how well they could cook and what they like to cook, and what facilities they had. I'm going to be very quick here. This is data this was a model that suggested that if we increase the dairy, how many hips will we avoid? Now, the French had a greater proportion of people with low calcium intakes, so you can see avoidance is quite high. When I look at Denmark and Sweden, Sweden was similar to Norway, so your intake is similar, and the Danish intake is similar to the Netherlands. So they're modest. But remember, that's overall. When people get older, they eat less, so therefore they may be not getting the amount of protein and calcium they need. And as I mentioned before, the intervention was relatively cheap. I'm going to move quickly through this one. This is policy. Current recommendations are here. This is Australia. This is fracture risk increase, which is from the WHO. This is where we demonstrated anti-fracture efficacy at 1100 milligrams. These were the servings. We used 3.5, and this is our serving sizes. Now, our serving sizes are different to here. This is your policies. So if I look at, for example, there's no specific requirement here, but they're the serving sizes for Denmark, and in Norway it's suggesting 3 servings a day. But if you look at the serving sizes, considerably smaller than ours. So what is suggested is providing around 600 milligrams. So in a sense, that extra 500 milligram has to come from somewhere. And as we mentioned before, we can't add more food on, so it may have to come from improving the nutritional quality of the foods they eat. Last slides. Key, policy change, which is what I'm working on. If we don't change policy, we can't change practice. So policy changes, practice changes, and education so that the staff can actually do it for themselves. So thank you for your time. I think I'm just on time. There you go. So thank you very much. And there's a QR code there. If anyone wants any more information, I can send you the papers. So thank you so much. And thank you for allowing me to speak it in English. And I hope there are lots of questions. Thank you.
Thank you so much. And there are a lot of questions. So I'll just start on the top, and please remember also that it's still allowed to raise your hand. Okay, so first question. Should dietary recommendations be more specified to certain age groups? For example, could it be beneficial to recommend 5 portions of dairy products per day?
Yes, in Australia we do have recommendations for over 70-year-olds. That was changed and is coming back. So when we look, I'll use dairy because that's what our intervention was. During adulthood it's 3 servings per day, and it goes up to 4 in older adults. So what we need to do with older adults is provide more nutritious food. So those servings of high quality, high protein quality foods are critical.
Okay, next one. Would you obtain the same results by giving the older adults supplements?
If someone would give me an extra $5 million, I can answer that question. The only evidence with supplements is with calcium and vitamin D supplementation combined. That's the only evidence that demonstrates anti-fracture efficacy. In relation to using oral nutritional supplements with tablets, don't know, can't answer it because that work has never been done.
Okay, next one. How important is dairy? Could you get the same result by removing nutritional poor food and replace it with other healthy foods, meats, grains, vegetables, etc.?
We focused for this project on protein and calcium. That combination would be very difficult. So if I provided meat for the protein, I need to get the calcium from somewhere. And for example, with vegetable sources, if they would achieve the 1300 milligrams, which is Australian recommendation, they need 4 kilogram of broccoli. Not feasible in older adults. So for us, that was the vehicle with a food that's familiar, but also had the nutrients that we were requiring. So very difficult, I think, if you were to use other foods.
Okay. Was it easy to get the chefs to add more dairy to the individual people, or was it hard to get them to do what you needed them to do?
Yeah, look, absolutely. That's probably one of the most important questions asked. Some chefs were very willing. Some chefs were resistant. The key was not to teach them or tell them how to cook. The key was not to change how they cooked, but to embrace their skills and what they like to use. So, for example, we have a lot of chefs from Southeast Asia, and they love condensed milk, which is in the can, because fresh milk's not available. So rather than put powdered milk in things, we just used the condensed milk and used that as a vehicle. So very much you need to embrace their skills. They are the cooks, they know how to do it. All we did was help provide them the ingredients that they used their skills and flair to make into edible and delicious foods.
There are lots of questions. Let's see. Could you get the same results with plant-based food rich in calcium?
Again, the research hasn't been done, so I can't answer that because it's not been done.
Okay. I would guess the elderly had more vitamin D in Australia than in Norway. Will it be possible to see the same results here?
The results, if they are supplemented with vitamin D to get them up to the same level of adequacy, and if their baseline consumption was deficient like ours, 600 milligrams of calcium and 0.8 grams of protein per kilogram body weight, yes, because they're deficient. But if their consumption is adequate, no extra food, extra anything is not going to help. So it's very much about if they're deficient, there is a benefit. And that's what you demonstrated with vitamin D. A lot of trials give healthy people vitamin D that are they're sufficient, and we're adding more. More isn't better.
In Australia, do you recommend lean dairy products? Should this be the focus, thinking about the diet for elderly people?
Yeah, so our National Heart Foundation has now changed. Previously it was all about reduced fat, low fat, but they've actually changed because if you look at the literature, there is no evidence milk, yogurt, cheese increases serum cholesterol levels, and we have that data as well. So I think if you look at butter and cream, there is evidence that it will increase serum cholesterol, but milk, yogurt, cheese, which is all that we used, is not associated with increased serum cholesterol. So there's no need. Also, remember, they can't eat a lot of food, so we need to maximise the nutritional content as well as the energy content.
We have time for a few more. How much nutritionally poor food did they eat before the study?
As you saw, it was quite poor. As you saw, they would eat one serving from the meat food groups. That's meat, poultry, seafood, eggs, legumes. One, they need 2. They were getting 1 serving of dairy. They need 4. We have a recommendation for discretionary food, which is, cakes and biscuits. It's up to 2. They were getting 6. And their fruit intake was just under 2, and their vegetable intake around 3. They need 5. So the quality of the food was poor, and as you saw, 75% of the soups and desserts and salads had no protein in them.
Let's see. What are the costs money-wise of implementing more dairy to the elderly in care homes compared to the supplements?
So our intervention cost, as you saw, about €0.5 per person per day, and that's across the entire group. And our supplements, now please, you're going to have to convert this, are about $4 Australian each. So that's probably around £2 British pounds. So it's about €2 each, so much cheaper, considerably cheaper.
Okay, so I think we're coming to an end for this part of the seminar. Please give Sandra Giuliano another hand for her lecture.
Is that the one you wanted? Is that right?
Thank you so much for being here. I know you also have a gift but it's without dairy products because I was told you're not allowed to leave the country with them. So a special gift for you.
I'll eat it before I go. Thank you.
So this first part of the seminar is now coming to an end, and we hope you will stay for the panel discussion afterwards. We will have a 15-minute break, and if you look behind you, there should be something to eat and something to drink. And you can also use the 15 minutes to mingle and talk, or to go to the toilet, which I already described is all the way down in the basement. Please be back here no later than 11:15. We will start the second part of the program. Thank you so much for your participation. kan dere høre meg? Hallo, alle sammen. Da klokken 11:15, og vi liker å holde tiden. Men det veldig hyggelig å høre at skravla går, for det tror jeg litt av poenget. Pausen kan være like viktig som det vi hører på scenen. Nå hører dere at jeg har skiftet til norsk. Nå skal vi ha en paneldebatt, eller i hvert fall en panelsamtale, fordi jeg har snakket med alle paneldeltagerne på forhånd, og jeg ikke så sikker på at de så veldig uenige, men de snakker fra litt forskjellig ståsted, så jeg tror dette skal bli veldig interessant likevel. Vi skal snakke i cirka 40 minutter, og så åpner vi opp for spørsmål, akkurat som i sted. Da tar vi spørsmålene bare muntlig denne gangen, det sånn å forstå? Ja. Og vi strømmer fortsatt, så dere klar over det. Så hvis dere har spørsmål, så må dere ta mikrofon. Så vi kjører da paneldebatten, og så tar vi spørsmålene på slutten av debatten. Så da har vi 4 personer med veldig god og litt forskjellig erfaring som vi skal få opp på scenen. Den første Katrine Borsenius. Du kan komme opp, sette deg her. Katrine klinisk ernæringsfysiolog i Bærum kommune, men hun også, og kanskje holdt på enda lenger, med å være en gründer og daglig leder av bramat.no og sunnogsprek.no. Og mange kjenner henne også kanskje igjen fra TV 2 og programmet Sunt og godt.
Ja.
Så,
det begynner å bli noen år siden.
Ja, det begynner å bli noen år siden, men det helt sikkert noen som husker det likevel. Men du kan få en applaus, synes jeg. Velkommen.
Takk.
Så har vi Arnt Steffensen. Du leder i Kost- og ernæringsforbundet Delta. Kom opp på scenen, du kan få en applaus. Forbundet organiserer alle som arbeider med matomsorg, og det mange forskjellige assisterende kjøkkensjefer, institusjonskokker, kjøkkenassistenter, lærlinger, studenter og matverter, som vi skal snakke om litt etter hvert. Så velkommen til deg også. Så har vi Tove Elise Madlam. Du medlem av Helse- og omsorgskomiteen på Stortinget. Du sitter for Arbeiderpartiet. Velkommen opp på scenen. Få en applaus. Men har også lang erfaring fra hjemmetjenesten, blant annet. Så også ikke bare en politiker på Stortinget, men også en praktiker med mye erfaring å bygge på. Og så har vi Gøril Andersen. Du 3. kandidat for Bærum Fremskrittsparti. Kom opp. Det blir bortest der, da. Du får ikke velge. Ja. Men du heller ikke bare politiker. Du utdannet radiograf og har lang erfaring fra dette feltet. Og du har også jobbet i både Nestlé og Nutricia med berikede næringsdrikker. Så en applaus til alle sammen. Dere har jo sittet her og hørt på foredragene. I hvert fall en del av dere har fått med dere det meste. Så vi kan også prøve å komme litt inn på det etter hvert. Når vi har hørt disse foredragene, veldig spennende forskning, det fremstår jo som det ikke noe tvil om at ernæring veldig viktig, og at vi trenger fokus på det. Og vi skal snakke litt om hvordan man skal få det til i praksis etter hvert. Men selv om en del av foredragsholderne har vært inne på det, kan vi begynne med virkelighetsbeskrivelsen. Hvordan står dette til? Hva situasjonen i Norge når det gjelder ernæring og eldre? Hvem vil begynne? Ja.
Jeg kan godt si noe, fordi at jeg jo, det jo mange andre som burde sitte her enn meg, for jeg har bare jobbet 2 år i kommune, men det kanskje litt fint også, for da har jeg kommet utenfra og sett hvordan det står til, og jeg må jo si, jeg skulle bare jobbe et prosjekt, men så ble jeg så revet med når jeg begynte at jeg har fortsatt, og jeg var jo sjokkert over hvordan det står til. Og det handler jo mye om at det alt for lite ressurser innenfor ernæring og matomsorg i kommunene. Og mat og ernæring jo tross alt 2 fag. Men det jo ikke noe som blir... Altså i kommuner så mener man jo at mat noe alle bare skal gjøre i tillegg til, eller og innimellom alt annet. Ikke minst da på sykehjem. Og da blir det jo ikke bra.
Tove Elise, du hadde en hånd i været.
Ja, jeg har lyst til å fortsette det som du sier, og bli, jeg håper å si, veldig politiker med en gang. Altså Helsepersonellkommisjonen peker jo på mange viktige ting fremover, men han peker på en veldig viktig ting. Det er den tverrfagligheten, som du sier. Så ernæring er faktisk et fag. Men det, på en måte, det blir aldri forkynt, holdt jeg på å si, hvis jeg skal bruke et vestlandsk uttrykk. For han er så veldig en opplært til å se på den syke biten av mennesket, og skal han inn og kompensere og støtte det, og så glemmer han at ernæringen ligger i bånd for alt. Altså skal du kunne rehabilitere og få en god helse, så må du ha en god ernæringsstatus i bånd. Så dette henger, som Gro sa, at alt henger sammen med alt, og det viser jo absolutt dette seminaret så langt, at alt henger faktisk sammen med alt.
Og det skal vi komme nærmere inn på etterpå. Arnt Steffensen, hva vil du, hvis du skulle gi en virkelighetsbeskrivelse, sett fra ditt veldig praktiske ståsted egentlig? Hva er problemet? Eller problemene?
Det veldig sammensatt. Det som virker det ikke?
Nei, jeg synes jeg hørte det, at den ikke virket. Ja.
Det sammensatt, og det handler mye om organisering. Hvis vi ser på sykehjem i Norge, så det slik at cirka halvparten av sykehjemmene de har produksjonskjøkken på stedet, mens den andre halvparten får da maten levert fra et sentralkjøkken eller fra næringsmiddelindustrien, altså de velger andre løsninger. Og når man da fjerner et produksjonskjøkken fra et sykehjem, da fjerner man gjerne kokkene også. Og dermed i praksis så det sykepleiere, helsefagarbeidere, assistenter som ikke nødvendigvis har matkompetanse eller ernæringskompetanse, som skal gjøre de oppgavene da knyttet til mat. Og det handler ikke bare om denne middagen som alle så opptatt av, men det også om frokost, lunsj, mellommåltider, kveldsmat, og ikke minst renhold forbundet med dette her, og alt administrativt arbeid som knyttet til det. Fordi det et regelverk og et lovverk knyttet til det å lage mat, og bare fordi du fjerner kokkene, så fjerner du ikke regelverket. Så det handler om organiseringen, og hvis man fjerner kjøkkenet, så må man rett og slett ha en løsning som tar høyde for det.
Vi skal komme mer inn på alle disse tingene etter hvert. Gøril Andersen, Bærum FrP, kom med en virkelighetsbeskrivelse.
Jeg vil jo si at før du skal evne å gjøre noe med noe som helst, så må du faktisk vite hva omfanget av det du skal gjøre noe med, og jeg tror jo den uvitenheten noe av det som begrenser oss i å få bukt med problemene og faktisk komme i forkant, den berømmelige forebyggingen som vi alle sammen vet det beste. Og jeg tenker det at det kom regler at vi skal skrine for ernæring. Det kom i 2009, hvis ikke jeg husker helt feil. De bytta ut ord som bør over til skal, og jeg tenker det var en grunn til det, men uten at det hadde noe stor effekt. Vi skriner cirka, vi vel rundt 50% av de pasientene på sykehjem i Norge blir vurdert for risiko for underernæring, og av det så finner vi altså ut at det opp til 40-50% som faktisk da i denne risikosonen. Det av halvparten som vi faktisk har skrinet. Og da tenker jeg, hvis halvparten av beboere i sykehjem i Norge i risikosonen eller underernært, da begynner det her å bli et ganske betydelig problem. Og jeg tror det viktig at folk skjønner at ernæringsstatusen ligger som en base for det medvirkende årsak i utvikling av de fleste sykdommer. Så viktig den. Og jeg mener at der begynner alt arbeidet. Så jeg tenker vi må fortelle historien, vi må prøve å belyse hvor stort omfang det her i, for å få viljen til å gjøre noe, og midlene til å gjøre noe.
Jeg har notert meg at Helsedirektoratet anslår at 1 av 3 voksne pasienter i sykehus underernært, og 2 av 5 eldre i sykehjem eller i behandling i regi av hjemmetjenesten. Det ganske dramatiske tall. Så hvis man egentlig ut fra de foredragene vi har hørt, da, vi vet jo egentlig hva som skal til. Det ikke sånn? Det skal være gode, næringsrike måltider, servert på en riktig måte. Hvor det butter? Hvorfor har vi denne situasjonen? Ja, Tove Elise?
Jeg tenker det handler mye om tid, som allerede nevnt. Som du sa innledningsvis, så har jeg erfaring fra hjemmetjenesten. Altså, vi hadde en pasient som kom inn til oss, som vi fikk beskjed hadde langt kommet jeg var dement, hadde utviklet en demenssykdom, hadde mistet språk og alt dette her, som følger med. Vi så jo at det kliniske blikket var jo enkelt å se, damer var jo underernært, men hun kom inn, altså vi fikk mat inn, ofte måltider, fikk drikke, altså smilet kommer tilbake, språket kommer tilbake. Altså det viser jo bare hvor viktig det er å ha tid. Og denne damen hadde jo hatt hjemmesykepleie, og de hadde gjort alt de kunne. De kom med nydelig, ferdiglaget mat hver dag, for det har vi på vårt produksjonskjøkken i min kommune. Men det hjelper jo ikke det når de måtte springe med en gang, og så setter jo da damer maten ned til katten sin. Så katten ble jo bare større og større, men hun ble tynnere og tynnere. Og vi kan gjerne le av det. Og det er sånn, jeg kjenner jo at det gjør meg vondt, både som politiker og helsepersonell i den situasjonen, men det er virkeligheten. For altså, her er ikke nok tid, og da håper jeg jo at regjeringen nå, med sin nye stortingsmelding og reform om å styrke hjemme, altså bo trygt hjemme, altså det å styrke hjemmetjenesten, gi de som jobber i tjenesten god nok tid til å være der, og ha tillit til at de har kompetanse og gjør det de skal. De sitter ikke der og bare tuller. Altså, du har jo i dag 10 minutter hos fru Olsen, så har du 15 minutter hos herr Jensen. Liksom helt rigid. Gi tilliten til de tilsette. La de få lov å bruke den tiden hver og en trenger. Og så tenker jeg at dette vil ordne seg. Det høres ut som da skal vi sitte hele dagen hos fru Olsen, men det er jo ikke det handler om. Men akkurat i dag så ser jeg at det er der jeg må være, for hun trenger mer tid. Så den tilliten og tiden tror jeg vi må begynne der, og så kan du si det er gjerne en illusjon, men jeg har virkelig tro på at det er det handler om. Altså.
Arnt Steffensen?
Jeg vil bare støtte opp om det du sier her. Det harmonerer også med det vi hører fra våre kanter, at det handler ikke bare om at maten skal komme fram til pasienten, men man må jo faktisk sørge for at den blir spist opp. Og hvis ikke den blir spist opp, så har den jo ingen verdi. Og vi får jo mange øyenvitneskildringer om at ja, men vi kom da til denne damen som bor hjemme, og kjøleskapet var fullt av mat, og hun var underernært. Så det hjelper ikke at vi får maten fram til pasienten, men vi må rett og slett sørge for at den også blir spist.
Vi kan jo følge opp litt med det og snakke om hjemmetjenesten, for det er jo et mål at folk skal bo hjemme så lenge de kan. Og det krever jo også noe annet av det dere er inne på, nettopp at man ikke nødvendigvis kan anta at de spiser maten selv om de får den. Og så sier du, Tove Elise, at de må få tid, men det har vi jo snakket om i mange år. Så hvordan gi dem den tiden? Hvor skal den tiden komme fra?
Det som også er en del av målet for å styrke hjemmetjenesten, det er jo at du øker grunnbemanningen. Det er i hvert fall et virkemiddel regjeringen er opptatt av. Og vi må også jobbe på en annen måte. Altså, igjen tilbake den tid jeg var i hjemmetjenesten, så hadde jeg en liste som var lang i et vondt år av alle de jeg skulle innom. Det var ikke bare et problem for meg, men også for alle de jeg kom til, fordi at de stadig fikk nye folk å forholde seg til. Så faste team, alle så godt som du klarer i størst mulig stilling, for da får du den kontinuiteten. Da kan jeg kjenne igjen, jeg kan se på brukerne av hjemmetjenesten at ok, her er det noe som er i ferd med å endre seg. Hva er det som skjer? Så kan jeg diskutere det selvfølgelig med henne, men også med mine kolleger. Ser dere det samme som meg? Og det klarer du ikke hvis du har 40 ulike personer du skal forholde deg til. Så øke grunnbemanningen mest mulig i størst mulig stilling. Og igjen den tiden og den tilliten til at en har den kompetansen og en har et godt klinisk blikk som observerer. Og ikke minst tilbake igjen til ernæring. Det må inn som en viktig del av det de vi samtaler med og den jobben en gjør ute. Da tror jeg at en kan få en hjemmetjeneste som blir bedre. Og så har jeg lyst til å si at de som jobber i den tjenesten i dag, gjør en fantastisk jobb. Det må ikke være det som er bildet, at det er grusomt. De gjør så godt de kan ut ifra de ressursene. For det er dedikerte, flotte mennesker der ute som virkelig står på.
Vi skal snakke om løsninger etter hvert, men vi skal oppholde oss litt lenger i problemene. Gøril, hva tenker du om det som blir sagt her fra Tove Elise? Hvordan skal man løse dette? Hvis vi holder oss til hjemmetjenesten nå først.
Ja, jeg tror jo det er jo en kjent sak at mangel på kunnskap rundt den her er et problem. Og det tror jeg er viktig å løfte den kunnskapen til de som jobber med det. Jeg er også veldig opptatt av det at man ikke skal ha en personlig mening om hun har spist godt eller ikke har spist godt i dag. Det må være et måleverktøy. Så lenge som man ikke sitter med en kunnskap at man skriner ved å svare det svaret der, så tror jeg det er viktig at vi snakker samme språket for alle pasientene. Det var litt som det ble sagt i sted, at det er ikke så greit å se på den mannen på 100 kilo at han faktisk er underernært. Men han kan altså være det. Så det er ikke øyet ser ikke det her. Derfor må vi ha et verktøy som gjør sånn at vi har helt klare rutiner. Det er om å sette ting. Jeg skjønner at vi har for lite ressurser. Jeg har kjemperespekt for dem som jobber ute. Men hvis man ante effekten av det å komme litt i forkant av problemet, hvor mye tid og ressurser som er spart hvis vi klarer å komme til et punkt at hver enkelt pasient har en bedre ernæringsstatus, så tror jeg faktisk at den gulrota der er så stor at det er viktig å gå etter den. Vi har ikke tid til å tenke, akkurat nå er det bestemora mi det gjelder. Jeg har ikke lyst til å vente til at det er mammaen min vi snakker om, til at det er meg selv vi snakker om. Det synes jeg er klar over realismen sier at det tar tid, men på et eller annet tidspunkt så må man begynne å ta en avgjørelse og begynne å lage prosedyrer og begynne å være tydelig i hva man skal gjøre. Vi kan ikke sitte og vente til generasjon etter generasjon har avlidd med mulig underernæring.
Katrine, du begynte med å si at det å være ny et sted kan jo også være en veldig fin måte å se ting med friske øyne. Og du sa at det var flere ting som overrasket deg, eller du brukte til og med ordet sjokkerte, tror jeg. Kan du beskrive litt nærmere hva det var som overrasket deg sånn? Mer spesifikt?
Først så vil jeg si at jeg er egentlig enig med det alle her sier. Og så er jeg veldig opptatt av, nå svarer jeg egentlig ikke på spørsmålet ditt, men bare så vi jeg er veldig opptatt av at når vi jobber med ernæring, så må vi komme inn veldig, veldig mye tidligere enn det vi gjør nå, fordi vi ender fort med å snakke om sykehjemsmat eller hjemmetjeneste. Og de som har hjemmetjeneste eller er på sykehjem, de er veldig gamle og veldig syke. Og når vi i Bærum nå jobber, vi må inn og jobbe sykehjem, hjemmetjeneste, forebyggende, alt som er. Når vi jobber på sykehjem, så har vi sett at der er screeningbiten kanskje mindre viktig enn matomsorgsbiten. Der jobber vi med matverter og gode måltider, og det er en veldig viktig ting der. Hjemmetjenesten, der handler det mye om tid, ikke sant? Og der vi skal lære opp hjemmetjenesten, men det er jo nesten litt fortvilet å stå og lære dem opp og bare vite at de har jo ikke tid, ikke sant? Og folk sitter der ensomme eller demente og spiser ikke. Og det handler veldig mye om tid og kunnskap. Så da er vi der, og så er vi jo da på dette med å forebygge. Ikke sant? Begynne når vi er i min alder eller yngre. At fastleger,
når vi snakker om løsninger.
Det er liksom der vi må...
Men en ting jeg hadde lyst til å spørre deg om, fordi du sa da vi snakket sammen før dette arrangementet, så sa du at en ting som også overrasket deg veldig var mangelen på å forstå at ernæring er et fag, og mangelen på ernæringsfysiologer. Hvorfor er det sånn? Sånn er det jo, og det vet jo alle vi som jobber med ernæring, at ernæring er noe alle kan noe om, alle syns noe om, alle deler, de er på sosiale medier. Det er på en måte, hvis du skal fikse noe elektrisk, så ringer du en elektriker, men hvis det er ernæring, så kan liksom bare alle gjøre det. Så det er jo litt sånn. Og alle har et forhold til mat. Alle kan på en måte lage mat og har meninger om mat. Og særlig sånn nå når vi har jobbet på ett sykehjem spesielt, så ser vi jo da at det er akkurat det som er problemet, at det er ikke en fast stilling å jobbe med mat. Det er jo ikke noe, de har flyttet kjøkkenet ut av sykehjem, og så tenker de bare at alt som har med mat å gjøre, skal alle gjøre. Så når vi gikk inn der og satte det i system, så klarte jo vi for lederen, som også trodde at mat var bare litt sånn som alle bare gjør, så satt vi henne til å jobbe som matvert da. Og så plutselig så skjønte hun hvor mye det var. Og så handler det da om å gjøre om på
altså sette ting i system, få gode rutiner, skjønne at selve bare måltidene, matservering, bestilling av mat, hva skal være i kjøleskapet, hva skal lages til, hvordan skal man gjøre måltidssituasjonen hyggeligere. Alle disse tingene en fulltidsjobb, og det derfor vi vil ha matverter inn der. Og det har vi måttet jobbe mye for å få dem til å forstå.
Men sånn som jeg hører dere da, så ikke problemet egentlig at det ikke finnes god, ernæringsrik mat, eller det det?
Ikke i Bærum, synes jeg. Jeg jo ansatt under et storkjøkken som lager kjempegod energi.
For nå så vi jo for eksempel foredraget til Sandra Juliano, at det var stort rom for å forbedre næringsinnholdet i maten. Men det der problemet ligger, oppfatter dere?
Jeg tror det hadde vært en veldig fin ting også. Ja. For det en av de første tingene vi gjorde, definere mattilbudet. Hva skal serveres på dette sykehjemmet her? Hva skal serveres i denne kommunen her? Og da kunne man jo absolutt brukt hennes resultater til å gå inn enda mer og se på hvordan man kan få inn mer meieriprodukter, for eksempel. Da. Så det en ting, men det største problemet at de som serverer maten ikke skjønner hvordan den skal varmes opp, eller hvem som skal ha hva, eller hva man kan bruke som tilbehør.
Du skal snart få ordet, Tove Lise. Jeg skal bare spørre Arnt Steffensen først, fordi du organiserer jo de som lager maten. Hva ditt syn på dette? Det maten som lages god nok, eller det stort rom for forbedringer av næringsinnholdet i maten? Eller hvor det, hva problemet der?
Maten som serveres på sykehjem og institusjoner god nok. Den laget da på grunnlag av kosthåndboken som Helsedirektoratet har utarbeidet, som da en beskrivelse av hvordan måltidene på et sykehjem eller for andre sakergrupper skal settes sammen. Det forskningsbasert, basert på ikke bare rapporter sånn som vi kikket på nå her i stad, men tusenvis av lignende rapporter som da trekker i samme retning. Så du kan si at den maten som lages, som serveres ute, den i utgangspunktet bra. Så problemet jo hvordan den blir behandlet da i sluttleddet. Fordi når maten forlater kjøkkenet, så kan du si at da den bra. Men hvis den for eksempel tilberedes feil, hvis den står i ovnen for lenge, slik at du liksom bare får en grøtmasse i stedet for det som skulle være friske, fine grønnsaker, så blir jo resultatet gærent. Så du kan si at det organiseringen i siste leddet, det å ha matkompetansen ute på avdelingene, når den ikke til stede, det der det gjerne går dårlig. Men maten som lages på kjøkkenene innenfor institusjons-Norge, den bra.
Men bare ett oppfølgingsspørsmål, skal dere få ordet. Men når du da ser denne menyen da, som vi fikk servert av Sandra Juliano sitt foredrag, for da gikk det sånn sukk gjennom salen når folk så at det var, det var mye saft, og det var mye kaker, og det var mye ting som kanskje ikke var helt optimalt. Gjenkjenner du ikke det i det hele tatt, eller?
Det vil jo alltid være variasjoner, men hvis du ser en gjennomsnittlig meny på et sykehjem eller et sykehus, så de har gjerne sånn 3 uker eller 4 ukers menyer som rullerer. Og som regel så det da snakk om en 30-40 forskjellige middagsretter som da går igjen i det daglige, og så kommer selvfølgelig dette med tradisjonskost og høytider i tillegg. Bare sånn til å sammenligne, en vanlig norsk husholdning har gjerne en 10-12 middagsretter som man liksom jonglerer med i det daglige. Så du kan si at utvalget og variasjonen ute på norske sykehjem, den vil jeg si større enn det som hjemme. Men så vil det jo selvfølgelig alltid være opp til den enkelte kjøkkensjef og den enkelte matvert, det enkelte sykehjem, de som skal ta seg av variasjonen, fordi man har et sentralkjøkken som lager, kan du si, som lager middagsmenyene, men det frokost, lunsj, mellommåltider, det lages lokalt. Og der kan det nok være mye forbedringspotensial for å få til variasjon, dette med matglede, utseende og så videre, for å skape appetitt.
Tove Lise Madland, du hadde en hånd i været.
Ja, jeg har lyst til å trekke frem det som flere har sagt her, dette med, altså, når maten blir lagt på bordet, hvordan skjer det? Altså, jeg vet av egen erfaring hvor viktig det å ha en duk på bordet, ha lys på bordet, altså gjør det koselikt, hvis jeg kan få bruke et sånn rogalandsk uttrykk. Men det som Sandra sa, så jeg synes noe av det viktigste man tar med oss, det å kjenne livshistorien. Altså det veldig mange som kommer, ikke bare at de får en kognitiv svikt, men eldre mennesker I dag veldig hyggelige mennesker som aldri skal være til bry. De vil ikke få kreve noen ting, de forlanger ingenting. Og så liksom, ja, hva ønsker du å ha på skjeva di, for eksempel? Og stiller du det spørsmålet, så nei, det samme for meg, sant? Og så tar en på noe uten at kanskje så liker jo ikke den personen det. Så det der å ha kjennskap til hver og en av de som skal innta det måltidet, jo kjempeviktig. Så tusen takk for at for livshistorie veldig viktig I eldreomsorgen, og I demensomsorgen det å kjenne pasienten kjempeviktig, helt avgjørende. Men også at du la vekt på det når det gjelder ernæring. At den også obs på hvor viktig det å ha den livshistorien, og barn kan fortelle mor likte det. Og så det litt sånn med generasjoner også. Jeg tror vi skal være så ærlige og si litt om det også. For det klart, de som eldre I dag vant med et norsk kosthold, for å si det sånn. De ikke vant med en pizza på lørdagen, for eksempel. Det kan være også de har problemer med å spise den pizzaen. Altså, det så mange ting. Så igjen, ernæring et fag. Du må på en måte vite hva en skal gi, og så igjen kjenne pasienten for alt I verden, eller brukeren.
Katrine, du hadde også hånden oppe.
Jeg glemte nesten hva jeg skulle si, men middagen jo greit, for det kommer fra storkjøkken, sånn som det hos oss. Men så som du sier, så det alle de andre måltidene som da skal serveres eller tilberedes av da pleiepersonell. Og vi har jobbet mye på en korttidssykehjem, hvor de skal ernæres opp. Og der så vi jo, da vi kom inn, så var jo alle pleierne løp mellom pleie og kjøkken og smurte fortløpende og stilte akkurat det spørsmålet som du sa, hva vil du ha? Og da sier de fleste, eller veldig mange, nei, jeg vet ikke, det det samme for meg, jeg kan godt ta hva som helst. Og så smurte de da fortløpende. Maten sto ute 2 timer, det jo heller ikke lov, inn mellom pleie og smøring. Så skiftet de bort det, fikk inn matverter, lagde fat med snitter, som vi kaller det, med masse pålegg. Når de kommer inn, så det velkommen, sett deg ned, her maten. Sånn. Og da går de altså fra en halvskive med syltetøy til da 3 halve skiver med egg og alt som Så det sånne enkle grep som viktige da. Så, og det jo, ikke sant, mat fra storkjøkkenet, den bra. Men alt det andre som gjøres der ute, der trenger man folk som vet hva de driver på med.
Ta vel I seg.
Og da har jeg bare lyst til å løfte opp det som du sier med matverter, og det ser en jo at veldig mange kommuner nå begynner med. Stavanger har sine matverter, Oslo har hatt det samme. Du får en helt annen ro rundt måltidet, for ja, vi som har jobbet der har vært med på den runddansen, og springer fra et værelse til inn og smøre noe til herr Olsen, og så det tilbake igjen og fullføre det stellet som du egentlig hadde begynt på. Så det jo ikke løy at en ikke våger å spørre, og en bare svarer nei, det det samme for meg, når en ser at de ansatte springer sånn som de gjør hele tiden. Så det jo en, ja, nå håper jo jeg at det der blir politisk vilje, og at vi sammen kan klare å løse de utfordringene, for jeg skal være ærlig og si det, at det ingen regjering, nå sitter jeg og representant for regjeringen, jeg tror ingen regjering har levert godt nok når det gjelder eldreomsorg, om man har vært blå eller om man har vært rød. Så ærlig skal jeg være.
Vi har jo snakket mye om trivsel nå, hvor viktig det med trivsel og gjøre det koselig, som du sier. Men det jo også, selv om det noen ganger kan være vanskelig å snakke om økonomi, så handler jo det også om økonomi. Nå har vi snakket om livskvalitet, så da våger vi å gå over på økonomien. Og alle dere har vært opptatt av, når jeg har snakket med dere før, på dette hvor utrolig mye penger det å spare på forebygging. Det har vi også sett på et av det siste foredraget som vi hadde her. Så når man ser de regnestykkene, så fremstår det jo, og dere som politikere, som helt opplest og vedtatt og uproblematisk at man må satse veldig mye på forebygging, og det vil løse mange problemer, både ikke sant, færre innleggelser, mindre bruk av, altså det allerede mangel på helsepersonell, som vi trenger å bruke de til oppgavene vi allerede har. Hvorfor det da likevel så utrolig vanskelig å få med folk, politikere, snakker jeg med noen folk, på forebygging? Det jo helt opplagt. Først, Gøri.
Jeg tenker som så at forebygging jo dit vi vil, og det dit vi vil være. Og jeg tror ikke det problemer å få politikere til å snakke om forebygging, for jeg synes nok knapt det snakkes om annet enn forebygging. Jeg vil jo heller snakke om å ta det første skrittet og faktisk begynne å gjøre noe. Sånn som vi har gjort i Bærum, vi har tatt skrittet, det satses veldig på ernæring. Man har klart å få matverter, man har klart å få kliniske ernæringsfysiologer inn, og da skjønner du at da begynner det å skje noe. Men du må være villig til å ta den investeringen der og kjempe for det. Fordi og da får du noen som jobber kvalifisert ut I feltet der. Så jeg tror...
Men hvem kjemper for det da? Hvem det? Bortsett fra dere?
Jo, men jeg tror...
På hvilket politisk nivå kjemper man for dette? For nå har vi akkurat hørt Tove Elise sier at det ingen regjering som har satt dette høyt på agendaen.
Alt blir jo alltid satt opp mot hverandre når du sitter med helsepolitikk, så det veldig mange ting, ikke sant? Men jeg tror... Egentlig så finnes det ikke politisk uenighet om den her. Men det mangler politisk handlekraft. Det synes jeg faktisk. Det ingen som tør å sette det her I et prosjekt. Og jeg jo politiker på deltid og jobber med prosjekt fra 8 til 4. Så det klart, jeg elsker å føre ting fra A til B. Det tar ganske lang tid innenfor politikken. Så jeg vil vel alltid være en liten sånn poker som synes at nå går vi I gang. Og så tar vi og så måler vi oss selv underveis. Og jeg tror det må flere som må tørre å initiere, og tørre å bli litt upopulær inne I salen der du sitter og snakker, for å rett og slett poke, for å få det til å skje noe. For å bruke et.
Arnt Steffensen, du hadde hånden I været.
Jeg tenkte bare jeg skulle skyte inn sånn liten fakta om hva som skjer nå I Helsedirektoratet. Fordi I forlengelsen av eldrereformen Leve hele livet, så fikk vi nå en nasjonal ernæringsstrategi for eldre. Og I den strategien så ble matverter løftet opp som en mulig vei å gå, de stedene hvor det ikke var kjøkkenpersonell på stedet. Og de har da gitt til Helsedirektoratet oppdrag å lage en kartlegging om hva en matvert, hva skal en matvert kunne, hvordan skal man gjøre dette sånn rent konkret. Den de ferdig med, så den går nå på SIRK I departementet for at den skal ha på seg godkjennes og sette røde streker. Så det som blir spennende nå, da, det blir jo selvfølgelig å se, liksom, blir det en bør, eller en skal, eller en kan? Og jeg tror vel at vi ender med en bør, og det fordi at for å jobbe med mat på institusjoner I dag, så trenger du ikke noe fagbrev eller noe autorisasjon. Så det å tro at det da skal komme en autorisasjon eller krav om fagbrev for å jobbe som matvert, det tror jeg ikke. Men bør veldig bra. Så den venter vi litt I spenning på.
Og hvis jeg har forstått det, så jo et av de positive sidene ved matvert jo da at du, ikke sant, det mangel på helsefagarbeidere og sykepleiere, så heller bruke andre ressurser på å servere mat, og heller bruke de som har den helseutdanningen da, på andre ting. Hvem skal da være disse matvertene? Dere organiserer dem jo. Ja.
Altså en matvert kan... jeg leder for en organisasjon for kjøkkenpersonell. Jeg skulle gjerne sett at det var kokker på hver en tue overalt, men sånn det ikke I verden, og det mangler på kokker. Men altså, det kan være... Altså, man kan ikke sette hvem som helst til å være det. Fordi man må kunne litt om matlaging, man må kunne litt om kosthold, ernæring, dietter, spesialkost, de praktiske tingene rundt.
Men det kan man vel læres opp I uten å ha en 3 år lang utdanning?
Det kan man læres opp I, det kan man helt fint, men da må man ha et system på det.
Ja. Katrine, du ivrig nå.
Ja, fordi at, jeg jo enig, men ikke helt enig, fordi vi har jo testet ut dette her, og vi har testet ut flere matverter, og det vi ser at det personligheten som betyr noe. Det at du flink med eldre, du må kunne norsk, så du kan kommunisere, og du må være arbeidsom, for det en ganske sånn travel dag. Så skal vi, I hvert fall I Bærum kommune, vi lærer dem opp I spesialkost og hygiene og disse tingene her. Så en matvert trenger egentlig ikke ha videregående en gang, har vi sett. Og nå får vi inn matverter, ung arbeidskraft på helger og kvelder, som da 16-åringer som vi lærer opp, og kanskje klarer å få inn I helse- og omsorgsyrket Så ja, det trenger ikke være noe bachelor i
Så unge mennesker inn, både for å rekruttere dem, men også for å gi dem arbeidserfaring, da. Kunne man ha det som en alternativ militærtjeneste og jobbe et år i helseomsorgen? Gøril, du hadde hånden i været, du skal snart få ordet.
Jeg synes det litt artig å tenke på at vi har vel gjerne 200 000 elever i videregående skole i Norge. Jeg tenker ressurser, hæ? Og hva har de å tape på å faktisk møte eldre folk, sitte og ta et måltid med dem, lese avisen? Jeg tror det så mye gevinst, selv om selvfølgelig 16-åringen vil ha noen innvendinger på akkurat det der, hva som i det for han. Men vet du hva, jeg tror at man nødt med den eldrebølgen vi på tur inn i, med samfunnet sånn som det nå. Jeg tror det skulle vært så godt å få det faget der inn. Omsorg, 2 timer i uka. Det vil altså si 200 000 elever, 400 000 timer som vi faktisk har å plukke av for å gjøre det hyggelig, og gjøre det trygt, og gjøre det godt å bli eldre. Også av dem som bor hjemme.
Da ville de jo lært litt om ernæring selv også, som sikkert ikke ville vært å forakte. Du hadde også hånden i været.
Ja, jeg har lyst til å si det veldig kjekt å høre hva han har gjort i Bærum, og det tar jeg med meg videre. Men dette med matverter som nødvendigvis ikke trenger å ha noen formell utdanning, så tenker jeg, så jo, få de inn da, så jo det en stor mulighet til å kunne få at disse får praksis. Altså en kan til slutt ha et fagbrev på jobb. Så får du da altså en fagutdanning, du får et fagbrev. Og så vet jeg jo at det fagskoleutdanning som går på dette med ernæring. Så du kan jo, her kan du begynne på scratch, og så kan du bygge opp, og så får en det en trenger som helsepersonellkommisjonen peker på. Altså den mangelen det vil være på fagfolk fremover, da vil en jo kunne rekruttere enda flere inn i yrket. Og dette som du så spenstig hiver ut forslag om 1 års militærtjeneste eller siviltjeneste, altså det jo også noe av det som det ble jo nevnt i helsepersonellkommisjonen. Så jeg tror tiden kommet for å våge å tenke gode, spenstige tanker, så gjerne ikke vi politikere på Stortinget de beste ambassadørene til det da, men...
Men vi må jo få tenåringene vekk fra skjermen nå, så det jo, her det vinn-vinn på alle fronter. Nå vi jo inne på løsningene, og nå har vi snakket mye om matverter. Hvilke andre løsninger eller muligheter har vi? Gøril?
For jeg tenker jo, de løsningene du beskriver, det vet vi, det sånne løsninger som tar så lang tid, så vi kommer liksom ikke i gang i morgen. Men jeg tenker litt på hva har kommunene allerede i dag kjøpt? For det har de. De har gjort innkjøp, de har innkjøpsavtaler på alt av mat og ernæringssupplement og hva det måtte være. Det har de allerede innkjøp på. Og når de for eksempel gjør innkjøpene på det med ernæring, så får du alltid et spørsmål nå i norske anbud som det står, du skal levere service. Service undervisning. Sånn at alle kommunene i hele Norge har kjøpt gratis undervisning fra alle leverandørene av for eksempel medisinsk ernæring. Der vil de få opplæring i betydninger, de vil få opplæring i screening. Alle de tingene som vi sitter og sier vanskelig å komme til, det har kommunene allerede kjøpt. Og jeg tror det de færreste kommunene som klar over at de har kjøpt den pakken her. Jeg tror de egentlig sitter og sier at vi har ikke kapasitet til å lære opp. Nei, men nå vi der at vi skal gjøre mye. Vi nødt til å ta i bruk alle dem som med i næringskjeden for å hjelpe til med pasienter eller med eldre, hva det måtte være. Vi nødt til å bruke hele kjeden. For vi har
men du har jo fortalt meg at du har jo jobbet med dette både i Nestlé og Nutricia. Og du har også sagt at du reiste land og strand rundt for å drive denne opplæringen. Og hva møtte deg da?
Det møtte meg folk som kanskje ikke egentlig, for jeg får ikke rundt for å belære eller å peke. Min oppgave var rett og slett å belyse, og få litt interesse for rundt det her med maten. Og når jeg var på et sykehjem som jeg kom inn der, og man vet jo at når du blir eldre, så blir liksom evnen til å ta inn mengde mat blir jo dårligere. Da betyr jo det at det som på den tallerken må altså være gull, og det som i det glasset der må være gull. Det forbauser meg å komme på et sykehjem og finne Fun Light. Det 0, og du bruker altså 250 milliliter magekapasitet på 0 verdi. Og sånne ting tror jeg det viktig at man forstår. Og man trenger ikke å sitte og sove rundt i alle stolene på et sykehjem. Det kan være fest. Jeg helt sikker på at det kan være fest. Men da må de folkene der, de må tørre å prøve det, og så må de se at fru Hansen, hun livner litt til her. og følge opp på den, og jeg tror da kommer man inn i en god stim. Og jeg vet at det kjempegod undervisning som blir gjort. Det masse folk som står parat og reiser rundt. Noen kommuner, Trøndelag har vært ekstremt flink til å kapitalisere på det de allerede har kjøpt. Med å organisere undervisning både for hjemmetjenestene og for sykehjemmene. Oslo har vel også vært veldig flink på å hente de tjenestene inn. Men jeg har vært, vi hører dialekten min ikke helt herifra, så jeg har vært i mine hjemmeområder, og det gjør meg trist. Det sånn at jeg tenker, jeg er glad jeg blir gammel her, sør.
Og hva det triste?
Det triste at det ikke er fokus, det er dessverre dårligere resultater på, det litt flere folk som underernært og som i risikosonen i nord enn det i sør. Og det synes jeg trist. Kanskje det fordi det langt å reise og gi undervisning, jeg vet ikke, men jeg har prøvd.
Så matverter, opplæring som allerede kjøpt inn og betalt, det må man jo ta ut. Hvilke andre løsninger har man for å få, ikke sant, det vi egentlig snakker om da, det jo, dere i hvert fall mer eller mindre enige om at maten bra, ok, kan bli bedre, men ganske bra. Problemet å få det i de eldre, og servert på en god måte. Så flere løsninger. Ja,
jeg blir jo aldri ferdig.
Ja. Nei, Katrine først.
Deg først.
Nei, det også litt sånn å komme utenfra og se hvor mangel på struktur og system det da. Å sette ting i system. Altså, det jo veldig mye prosedyrer med alt, men de blir bare ikke fulgt da. Så når vi kommer inn og bare, sånn som vi har jobbet på ett sykehjem, prosedyrer fra maten liksom blir bestilt til den skal opp, hva skal være i kjøleskap, hvem skal gjøre hva, arbeidsfordeling. Det må jobbes med det da. Det må liksom lages gode rutiner for hvordan ting skal gjøres. En ting at man skal risikovurdere, men hvem det som følger opp? Hva skjer over tid? Har hjemmetjenesten prosedyrer for hvem det som går inn og ser at vekten går nedover og ikke holder seg stabil? Det jo det vi jobber mye med, å liksom få gode rutiner på ting. Så det tror jeg en viktig del av det.
Flere løsninger? Arnt?
Mer enn noe man skal huske på. Altså, det veldig mye snakk om hva som skjer på sykehjemmene. Men underernæringen som sådan, den oppstår jo gjerne ikke der. Den oppstår i hjemmet. Så hjemmeboende eldre, og finne de gode løsningene der, i samarbeid med hjemmetjenesten, det tror jeg kjempeviktig.
Tove Elise?
Det som du sier veldig, veldig viktig. Problemet oppstår hjemme, og ikke nødvendigvis når en kommer på institusjon. Da skal en jo gjøre det motsatte. Og da tenker jeg løsningene, dagsenter, bygge ut det. Det å ha matfellesskap. Altså, vi vet jo det at det mye kjekkere å sitte sammen med noen og spise enn det å sitte alene. Klart noen dager nok sikkert litt trøste, så da kan det være greit å gjemme seg hjemme, men på det jevne så det viktig med å sitte sammen og spise. Da spiser en jo mer, og det ser en jo, altså det vet alle vi som sitter her, at når du sitter sammen med noen så spiser du mer. Så muligheter til å bygge opp det, men da må det jo også være så jeg sier, altså, bo trygt hjemme handler ikke bare om helse, det handler faktisk om samferdsel. For det må jo være mulighet, det må jo være mulighet for den å komme fra der en bor, også til dagsenteret. Så igjen, alt henger sammen med alt. Her det mange ting. Det 5 departement som med på denne stortingsmeldingen som vi nå i løpet av høsten skal begynne å jobbe med på Stortinget. Så ja, jeg slår et slag for dagsenteret.
Ja. Men det du egentlig snakker om nå, nå skal vi begynne å avslutte og åpne opp for spørsmål, men du har sagt flere ganger alt henger sammen med alt, og når du snakker om dette med man skal bo hjemme lenge, mange ender opp med å bo kanskje hele alderdommen alene, eller i hvert fall store deler av den. Da handler det jo plutselig også om hele samfunnsstrukturen, om boligpolitikk, hvordan man har bygget boliger, hvordan nordmenn bor på en måte da, som kanskje i andre kulturer man ikke kjenner seg igjen i. Og det jo ikke så enkelt å løse. Men nå sitter jo du i helse- og omsorgskomiteen og skal kanskje ikke svare for regjeringens bosettingspolitikk, men det jo noe interessant i det da. Siden vi har det her da, så kan du svare på hva som helst, men det jo noe interessant i det, at vi har jo på en måte konstruert, med viten og vilje eller ikke, men et samfunn hvor veldig mange bor hver for seg, gjerne spredt over store områder i tillegg. Hva gjør man med det? Norge, ikke sant? Det jo ofte det man hører, at innvandrere som kommer fra asiatiske eller afrikanske land i Midtøsten får helt sjokk, ikke sant? Over denne måten å strukturere oss på. Det noe kan man tenke kreativt?
Ja, jeg tror, som jeg sa litt tidligere her, at en må nå våge å tenke nytt. Og klart, i Hurdalsplattformen vår så står det at vi skal ha likeverdige tjenester i hele landet. Det liksom et viktig overordnet mål. Hvordan skal vi da klare det når vi bor sånn som vi bor? Og vi må tenke også helt nye boformer. Altså, de omsorgsboligene som henger sammen med sykehjemmet der jeg jobber, der var det alltid venteliste. Det var kø ifra de var nye. Og det jo enkel matematikk, det skjønner til og med jeg som politiker, at klart, en vil jo bo der for det trygt. Det nær hjelpen. I motsetning til de omsorgsbolene som ble bygd ute i de ulike bygdene. Jeg kommer fra en relativt stor geografisk kommune med veldig sånn avskilte bygder, og alle bygder skulle ha litt av alt. Veldig god senterpartipolitikk. Nå jeg litt flåsete, men ordføreren han min nabo, så jeg kan tulle litt med det. Men altså, det liksom tanken en har hatt. Så kanskje må en også våge å tenke litt annerledes. Og jeg skjønner godt at våre nye landsmenn reagerer på måten vi bor på.
Arnt?
Bare følge opp den siste der, som interessant. Altså, de nye landsmennene, de jo ikke nye lenger. De har vært der i 50 år, og nå de i ferd med å komme på sykehjemmet. Og det vi må begynne å tenke litt på da, det hvordan møter vi den? Altså, hvis du har, la oss nå si at du 90 år da, du har levd med pakistansk matkultur i hele ditt liv, og så skal du plutselig gå over til norsk husmannskost. Det jo ikke sikkert at det den løsningen vi skal velge, så vi må begynne å tenke litt sånn også.
Katrine, du også hadde en kjapp hånd i været.
Ja, bare fordi at du må ikke avslutte før vi får snakket om å starte tidligere. Fordi at vi må begynne før. Hvis folk skal bo hjemme lenge, så må vi begynne før de gamle. Og det jo der vi virkelig må sette
og når
ressurser.
Før de gamle da?
Ja, det får si før. Ja, når vi voksne. Altså, vi har noe som gjør at fastlegene kan sende, om du har kreft eller kolesterol, eller diabetes eller overvekt eller undervekt. De må ha noe ute i kommunen som kan ta det imot. Ikke sant? Og folk må på en måte ta ansvar for egen helse. De må skjønne hvorfor det så viktig at de holder på muskelmassen, hvorfor de skal trene, hvorfor de skal spise sunt. Hvis flere gjør det for sin egen kropp og helse, så vil de jo antageligvis de vil ha større sjanse for å holde seg friske når de blitt gamle. Fordi det vi driver på med nå, det jo brannslukking i stor grad. Det vanskelig å ernære opp en gammel person som har hjemmetjeneste.
Gøril, en avsluttende appell. Hva viktigst for deg?
Si bare en. Jeg kan godt si enig, men jeg kan godt si en ting til. Vi må inkludere flere i dette arbeidet. Vi har mange, hvis jeg skal si omsorgsarbeidere, så kan jeg inkludere alt hva jeg vil. Men da vil jeg også nevne, selvfølgelig må fastlegene, synes jeg burde kanskje komme litt opp i kunnskap og kanskje interesse for ernæring. Det forbauser meg at kliniske ernæringsfysiologer de eneste som ikke kan skrive ut resept på ernæring. Det bare beats me, jeg skjønner ikke helt tankegangen der. Og så har vi apotekfolket. De som jobber på apotek har jo vist seg i undersøkelser, har meget stor tillit. De oppdager når en kreftpasient kommer innom og skal hente medisinen sin kvalmestillende fordi at han har begynt på cellegift. De spør han, har du problemer med appetitten? Og de vet med en gang at de skal gi han ernæring, altså som erstatning, tilleggsernæring. De har gjort det så mange ganger at vi nødt til å begynne å inkludere dem. Vi kan liksom ikke få en stor nok gruppe. Så hvis man begynner å inkludere alle, så har vi en mye større ressursbase enn det vi egentlig tror.
Nei, bruke hele laget kjempeviktig. Men jeg har lyst til å gå tilbake til dette med å begynne tidlig, dette med forebygging. Folkehelsemeldingen har et sterkt fokus på det, dette med å forebygge. Og når vi vet at av en 100-lapp så bruker vi 97 kroner til å reparere, da det 3 kroner igjen til forebygging. Det jo ikke bærekraftig inn i fremtiden. Så om vi vil eller ei, for meg som stortingspolitiker og både fylkes- og kommunepolitiker, så må vi blir tvinget rett og slett til å våge og måtte, altså ikke våge lenger, vi bare må. Og så det jo den utfordringen med dette vanskelige P-ordet da, altså det å prioritere. Det jo noe som jeg som politiker har på en måte sluppet å tatt inn over meg, for vi har alltid hatt, altså vi har jo pengene. Vi har hatt folkene, men nå går vi faktisk tom for folk før vi går tom for penger, og da kreves det at vi våger å gjøre noe nytt, hvis jeg skal kalle det det. Så det blir spennende fremover. Jeg gleder meg til å ta fatt på arbeidet, og jeg håper jo at vi kan få en god dialog om det på Stortinget da.
Ernst Steffensen, siste appell før vi åpner opp for spørsmål. Hva viktig for deg å etterlate publikummet?
Det finnes mange veier til god matomsorg, men hvis du ikke har kompetansen i siste leddet, da svikter det. Så sats på kompetanse.
Tusen takk. Da har vi noen minutter igjen, og håper at noen vil rekke hånda i været. Det jo veldig lurt å bruke sjansen når man har et sånt panel som dette her. Jeg ser allerede, en har grepet mikrofonen. Si gjerne hvem du også.
Ja, jeg heter Stine Sem. Jeg ernæringsfysiolog og jobber i Landbruks- og matdepartementet. Og der har jeg jobbet med mat for eldre de siste 10 årene. Finansiert av Landbruks- og matdepartementet. Og da har jeg 3 ting å si, og den ene tingen til deg, Gøril. I år bruker vi 750 000 kroner på et arktisk matgledekorps for å få bedre mat- og måltidsglede og helse i Troms, Finnmark og Nordland. Og du skal bare følge med på matgledekorpset.no. Der masse informasjon om dette. Og så kan jeg si, reklamen selvfølgelig at jeg nettredaktør for den da. Men det masse som skjer, og det kompetanse. Og det mange gode eksempler. Og så det jo det, siden dere politikere der, så ser vi jo også da at politikerne må se sammenhengene mellom det de ansvarlig for. For eksempel nå har vi vært opptatt av denne totalberedskapskommisjonen, hvor man ser på at det ikke bare hva man spiser, men hvor den kommer fra, og at den skal være der. Og det har vi også vært opptatt av i matgledekorpset, hvor man ser på innkjøpsordninger, hva produseres et sted, hvordan kjøpes det inn, hvordan brukes dette, hvordan serveres det. Og selvfølgelig må det være den eldre, det jeg kaller spisegjesten, jeg tror dere bruker ordet pasienter, men vi kaller det spisegjester, hva de faktisk har og ønsker. Fordi da blir det jo både glede og hygge og god ernæring og verdiskapning og bruk av lokale ressurser. Og da siste biten som et kjempegodt eksempel fra Trøndelag, hvis vi snakker om løsninger. Der hadde vi en matgledekorpskokk som brukte noen penger, 20 000 kroner brukte han på å kjøpe noe storfeskrått som han fikk inn på kjøkkenet. Og hva fikk de ut av det? Jo, de fikk mat for det dobbelte i pris. De fikk masse god mat som de folka som bodde på institusjonen hadde masse gode matminner med. De brukte hele dyret, det var bærekraftig, og i tillegg så ble det ble rimeligere, og kokkene synes det morsomt å jobbe. De synes det morsomt å jobbe med noe som du lager noe fra bunnen av, og du ser på gamle oppskrifter, og det jo bærekraftig. Slik at det skjer mange ting rundt omkring. Så det vi må... jeg har så mye å si. Men jeg tror nesten jeg kan si at det går inn på matgledekorpset.no, for der ligger alle sakene. Vi har også laget et e-læringsopplegg som vi virkelig håper at alle som skal jobbe på institusjoner, som en sommervikar for eksempel, må inn og ha et basis e-læringskurs, tar en times tid, slik at de har en forståelse for at det mat for spisegjesten der, og ikke hva som bra for meg. Og det veldig forskjellige ting. Takk.
Tusen takk for det. Det noen flere hender i været? Du kan få si en ting til, du, for det ingen andre som vil si noe. Ja, der kom det. Der kom det. Da skal du få vi får se da, vet du, om du kan få et avsluttende ord.
Beklager at jeg tok... Jeg heter Marit Bremer, jeg jobber ved Unike Friskvern, jeg jobber innen spesialisthelsetjenesten, og har et ønske om å kunne jobbe mer forebyggende. Men utfordringen som jeg ser da, at jeg har en bachelor i ernæring, en utdanning som egentlig ikke blir verdsatt, for det jo ingen stillinger fra kommunen. Altså vi ønsker å kunne bidra, men vi trenger at det utlyses stillinger. Så det savner jeg.
Hører dere det, politikere? Ja, Katrine?
Ja, det vet du. Sånn at, men nå har vi jobbet for kliniske ernæringsfysiologer først, da, så det var det vi fikk midler til, og da fikk jeg ikke lov. Men jeg helt enig i at vi trenger bachelor i ernæring også, kan gjøre masse forebyggende arbeid, men vi trenger også refusjonsordning, det mye vi trenger. Vi trenger lovpålagte stillinger for ernæringsfysiologer, vi trenger 1 ernæringsfysiolog per 10 000 innbygger, så det mye å ta tak i. Så det står jo, vi har jo kommet et godt stykke på vei i Bærum, men vi kan ikke gi oss her, for vi skal jo være i hvert fall 13 ernæringsfysiologer, pluss gjerne mange med bachelor. Jeg så ny at jeg tror det mulig, men vi får se.
Var det et spørsmål til der?
Ja. Randi Norheim, klinisk ernæringsfysiolog for tiden i Melk. Og jeg lurer litt på, det noe rom for at de pårørende kan bidra hjemme før de havner i en hjemmetjenestesituasjon eller på sykehjem? Det noe rom for opplæring til de pårørende? Eventuelt har de noe ansvar for at mor spiser godt? Hva kan vi bruke av ressurser der?
Hvem vil svare?
Ja, klart pårørende har vi ikke snakket om. De jo en kjemperessurs som viktige, som innom både titt og ofte ser at matvanen til mor eller far kan endre seg, så de viktige, men også pårørende skal ikke måtte ta hele dette ansvaret. Jeg tenker frivilligheten viktig å få en, det når vi heller ikke snakket om. Og pårørende igjen, sammen med hjemmetjenesten. Men som du sier igjen, den forebyggingen før en kommer inn før en kommer inn i og blir bruker av hjemmetjenesten. Så et samspill her, men klart, når du blir eldre, så vet vi jo alle sant, at ting endrer seg. Jeg vil ikke ha så mye mat, maten smaker ikke sånn som man gjorde før. Så ja, men igjen, vi må bruke hele laget, og da pårørende også en viktig bit der.
Flere spørsmål? Ja, fint.
Dag Lindheim, beredskapsleder i Tine, veterinær, kommunepolitiker og sønn av en smart mor, begynner dement. Jeg kjenner igjen veldig mye av de problemstillingene som blir løftet, men hovedfokuset mitt at hvis vi får opp en samlet erkjennelse av at det bare vinn-vinn ved å fokusere på riktig mat til disse, og at vi kommer på banen, ja, så må vi takle det, enten det i hjemmetjenesten og som pårørende, sånn, gjøre så godt vi kan for å få den gode maten inn i de menneskene, våre eldre. Dette må vi klare å løfte, og det gjelder både på nasjonalpolitikk, jeg som sitter i kommunestyret, og andre som da opplever dette på kroppen og kan være et sannhetsvitne. Det hjelper mye når vi snakker om det, at vi kjenner det på en måte på maten selv. Og jeg har sett hva det har gjort med mora mi, som satt borte i Skien og stura og var engstelig og begynte å bli feilernært, til vi fikk vippa henne opp og fikk henne på riktig spor. Du kjenner ikke dama igjen. Mine barn trodde aldri vi skulle få feire hennes 85-årsdag i august med et selskap. Det trodde farmor var for dårlig til. Hun strålte. Hun var nesten seg selv igjen, og det var i all hovedsak grunnet god ernæring over en 3-månedersperiode. Men jeg kjempekrevende i hverdagen. Hun lurer meg trill rundt på hva hun har spist og ikke spist. Hun får fantastisk mat fra et lokalt kjøkken på Marka. Jeg bor i Gran på Halland. Det ikke det står på. Men ikke sant? Altså, alt dette må være på plass, og så må vi være klar over de fallgrubbene som ligger der. Så vi kan ikke sove. Det er ikke nok å bare skaffe den maten, men den må i hvert fall være der. Og erkjennelsen av at det er der, og at det er vind, økonomisk, på alle måter. Og det handler ikke minst om god livskvalitet. Takk. Det ble litt mye.
Nei, det synes jeg var akkurat passe. Nå er klokken 15:15, og det var så fint at det ble siste ord til deg. Men så er det jo selvfølgelig sånn at meningen nå med å friste dere med gratis deilig lunsj er jo selvfølgelig at dere skal bli og diskutere videre over sunn, ernæringsrik mat. Så det håper vi at så mange av dere gjør. Og så må vi jo takke panelet. Arnt Steffensen, leder i Kost- og ernæringsforbundet. Tove Elise Madland, helse- og omsorgskomiteen for Arbeiderpartiet. Gøril Andersen, 3. kandidat for Fremskrittspartiet i Bærum. Og Katrine Borsenius, matgründer, kan jeg kalle deg det. Men nå er klinisk ernæringsfysiolog i Bærum kommune. Tusen takk til dere, og tusen takk til dere som har fulgt med oss hele veien.